Good evening, Dr. Abhinav sir.
Hi, good evening.
Welcome, sir.
So, Nati, you must be busy every day in the webinars and other meetings.
Yes, that's right.
Must be having a very, very tight schedule.
Yes, that's right.
That's good. You have so much of energy, so nobody has that much. You have so much of energy, so nobody has that.
Me, Anildeep Sharma, welcome you all. Thank you so much all to join this mega webinar of Retina Potpourri. It gives an immense pleasure to share with you today's panelist speaker and moderator. I welcome Honorable Dr. Mangat Dogra sir and Padma Shri Professor S. Natarajan sir, Dr. Sangeet Mitra sir, Dr. Ajay Kapoor sir, Dr. Amandeep sir, and Dr. Abhinav Dhami and Dr. Mohit Dogra sir for their important time for this event. And all of you are very well renowned name in our ophthalmology field. And also I thanks to my seniors also who supporting me for this event. And now I welcome Dr. Mohit Dogra sir once again, who's our moderator. Over to you, Mohit Dogra sir.
Thank you, Mr. Anil, and thank you for all the support to you and to Ajanta Pharma for helping us plan this webinar. And I welcome all the audience and all the viewers, the respected panelists and the presenters to this webinar this Saturday evening, titled Retina Potpourri. And as you can see by the varied topics that our presenters will be presenting in some time, we'll be covering different aspects of it of VR. We're going to start with none other than Dr. Sangeet Mittal, who's actually director of the Vitreoretina service at the Thind Eye Hospital in Jalandhar, Punjab, and is a very experienced vitreoretinal surgeon in north of India, and carries a lot of the workload of not only the state of Punjab but also the nearby areas. And he's going to be speaking to us today on surgery in proliferative diabetic retinopathy, especially for combined retinal detachments, which we all know are very, very tough to manage. Dr. Sangeet Mittal, sir, please.
Thank you, Mohit. Shall I share my screen now?
Please, sir.
Okay. Is my screen visible?
It is,
Yes.
sir.
Thank you again, Dr. Mohit and Ajanta Pharma, to give me this opportunity to present here in this Retina Potpourri session. And I am going to speak on proliferative diabetic retinopathy and combined RD or tabletop TRD's management. And I've titled this as an escaping the sweet spider's web, because what I feel is that diabetes is just like a spider, the sweet spider which engulfs everything. If you don't care of it, the web is built and you are going to lose slowly and slowly everything. So what happens is when the PDR happens, new vessels grow along arcades using posterior hyaloid as the scaffold. And then they progress to form fibrovascular and contractile epiretinal membranes. And these membranes then grow and contract to give rise to tractional retinal detachment, which again leads to the development of breaks and lead to combined rhegmatogenous and tractional retinal detachment. And these tabletop PRDs are very difficult to treat as the membranes formed are not glued like epiretinal membranes. They are not pasted but are nailed. Various nails are at the multiple epicenters of neovascularization. So you just can't peel it off. You have to be very careful when you are removing it. And there are the present techniques of segmentation, delamination, and en bloc dissection are there to take care of these membranes, but they are also limited. And the limitations of these present techniques, there are many limitations, but the main limitation is that finding the proper plane of dissection is very difficult. It remains a challenge in both these techniques. And there's often a need for fourth port or combination instruments, and the second membranes are missed, and the post-operative complications are more. And our experience, from our experience, we have observed that pre-operative anti-VEGF agents aid in bloodless membrane dissection, and dissection of membranes is easier if the plane of dissection is proper. But there is vitroschisis, which causes second membranes under the prominent membranes, and this second membrane is usually fused with the primary membrane at the optic disc. And it's easier to work around tractional points than to cut or peel them. So with this experience, what I have devised is a small technique of managing this combined retinal detachment or tabletop TRDs. And these steps include a pre-operative anti-VEGF, 27 gauge microincision vitrectomy, then around the table dissection, and sometimes we often resort to bimanual peeling. And by learning all these techniques, you can almost take care of all types of difficult membranes that you may face during the management of PDR. So first of all, going to the pre-operative anti-VEGF. So you can see this was a patient around 56 years old male who presented with this kind of picture. There was a whole web of new vessels growing all over the posterior pole, and there was a vitreofoveal traction, and the retina was detached. And this was the picture before anti-VEGF. You see how these new vessels, they look very dangerous, they look very angry. But after giving anti-VEGF, just one day after anti-VEGF, you can see that the membranes have the vascularity has decreased. And once the vascularity was decreased, we started with the surgery. And you can see how this pre-operative anti-VEGF has helped in decreasing the amount of bleeding which could have happened during the surgery. So these vascular membranes can now easily be removed. Like I generally use the vitrectomy cutter only to remove and to dissect these membranes around the nails. And sometimes when these membranes are very closely attached, a proportional reflux in current machines also works. Good to separate these membranes from the retina so that you can peel the remove the membranes from over the retina. So, and you can see post-operatively the patient was fortunate. He gave good vision of 6/9 over a period of time. This is another patient. You can see before anti-VEGF, there was again the membrane looked very vascular here, but after 3 days post anti-VEGF, the vascularity has decreased, and now we did a vitrectomy at this stage, and then vitrectomy can be done easily without any blood loss, and the post-operative results can definitely be better. Coming to the second thing, that is the 27 gauge vitrectomy, or in fact, not even 27 gauge vitrectomy. All small incision vitrectomies are helpful in achieving a better result in PDR with combined retinal detachment as compared to the broader gauge vitrectomies. So the advantages lies in the low flow rate, which causes lower turbulence and more stable retina while working close to it. And the small sphere of influence of this, the ports are very small, and the influence of this suction through the vitrectomy cutter is very small sphere, and it avoids retinal tissue being engaged in cutter while dissecting the membranes. And again, the small size of cutter, it allows it to go in even smaller crevices for effective membrane dissection. You see sometimes the nails are very close to each other, and this small size cutter helps in dissecting each of them properly. Again, the large opening, which is nearer to the tip of the cutter, it makes it easier to grasp, peel, and dissect the membranes with the cutter itself, thus eliminating the need for forceps or scissors. And smaller ports again decrease the incidence of post-op hypotony and subsequently vitreous cavity hemorrhages. So this was a 27-year-old girl, insulin-dependent diabetes mellitus, who had come from Himachal, and she had decrease of vision in both eyes. Both eyes had hand movements vision only, and you can see there were a lot of membranes and a combined retinal detachment in both the eyes. And this is an illustrative case just to share how 27 gauge helps in vitrectomy in diabetic retinopathy. It is with diabetic retinopathy, and this is a small. You see cutter is very small. It goes very close to the retina, and even very small spaces it can enter, and just we can dissect around the membranes. And you see just how I am going in between the membrane and the retina to dissect it. And again, I'm working very close to the retina, and it is not causing any turbulence. See, you can work really very close to the retina, mobile retina, even when you're doing dissection. So in this way, you can use your cutter only as a forceps and as a scissor to lift and peel and grasp and do whatever you want to do with the cutter itself, and you don't need any other instruments. And in fact, you can save time while making multiple insertions of different instruments. So this girl, we did a bilateral vitrectomy, both eyes at 1 week intervals, and both eyes she gained a vision of 6/9 eventually. Coming next to the next thing, that is around the table dissection. So what is around the table dissection? We first do a core vitrectomy, and then we detach the posterior hyaloid from the disc, and then we create a wedge between the posterior and the interior vitrectomy vitreous. We combine both we make a proper plane of dissection both posteriorly and interiorly, and then we dissect the membranes around the table. So we can attack the membrane from both outside as well as inside, rather than sticking to one inside out or outside inside dissection. And this is a small cartoon showing how you proceed with it. Do a vitrectomy, a core vitrectomy. Then you lift the membrane from the disc, and not too much, just a little bit, so that no breaks are formed. And then go to the periphery. Then you can attack the membrane from both inside as well as the outside. So this is a video showing how we do it. See, you lift the membrane from the optic disc, and then you create a wedge between the central vitreous and the peripheral vitreous. And you can attack the membrane now from both sides. See, the peripheral vitreous also will keep the membrane up while you are dissecting. So it becomes as a third hand, and you can avoid bimanual dissection in these type of cases. Again, you see smaller size of the cutter. You can go very close to the mobile retina and go in between very small spaces to remove it. Again, so the cutter is working both as a forceps and as a scissor, and also as the suction to remove all these membranes during vitrectomy. Again, the patient had a good visual outcome post-operatively. So the concerns in this technique, while using this technique concerns were from various ophthalmologists were that NVD, while we lifting up from the disc, can bleed profusely. But our observation is that it is very uncommon, and pre-operative anti-VEGF again minimizes this risk. And another concern was that it can cause iatrogenic tears, but only if the fibroblastic proliferation over the disc is pulled too high. Or in very severe cases with thin atrophic retina, it may happen. But again, even with the other techniques, this thing can happen in thin atrophic retinas or very severely fibrosed NVDs. The advantages of this technique is that it can be performed in all types of tractional detachments, and surgical time is considerably reduced. Complication rate was again very low, and it's easier to perform. Peripheral, which acts as a third hand to keep the posterior membrane held up. A fourth port or combination instruments usually are not needed and can be performed in the presence of vitreous hemorrhage. It can be done even in the absence of PVD, and second membranes are not missed and need not be dissected separately. Last is the bimanual peeling, which is again a very useful technique to counter membranes in these type of detachments. And it's especially helpful in very thick and highly vascular membranes in thin retina, or where the optic disc is not visible for around the table dissection to be performed. So what my technique of, this is again, this 46 years female, best corrected vision was hand movements only, and she was one-eyed. The other eye she had already lost to diabetic, combined retinal detachment and burnt out retinopathy. And this eye also she had a proliferative diabetic retinopathy with tabletop fractional detachment. And my technique involves the two modified instruments. One is the modified, what I call Meteor.
27 gauge endo-illuminator was used. The metal shaft of the light pipe was broken by moving it in a to and from motion.
And
the metallic tube is then
this
stripped
is a
off to
used light
reveal the
pipe, then
fiber
it is
optic
broken.
tubing.
The metal pipe is broken and removed from the fiber optic. And this fiber optic is then cut.
The light was brought out from the sclerotomy and fiber was cut from the middle with scissors and inserted
And
again.
this is cut, and then this light form gives you a very good light when you are doing a bimanual surgery. And the advantage is that the handle is still present, and even if you can't focus it on, you can either tie the handle with the sticking tape to the nose of the patient, or if still the light points upwards, you can ask your assistant to hold the handle and keep the light focused posteriorly. Another instrument is this is also a modified 27 gauge needle, which we call now, which we have developed it into an instrument which we call membrane stripper. And this is a sharp 27 gauge needle, and this has a hole just posterior to the sharp end, which acts as for either to remove comes during the dissection, or to inject fluids, or to inject viscous fluid for a viscodissection of the membranes. And this is an old video when I removed this membrane with the needle itself. You can see the light is coming from the endo-illuminator. The light which has modified is working well, and this needle you just hold the membrane from up, and then you can just do this peeling with the needle itself. You can cut at all the epicenters one by one. The advantage of this is that you can for the scissors or the cutter is that you can use it with both your right or the left hand, whichever you feel comfortable to get at the membrane. And only you can see the dissection can be completed with the needle itself, and no need for any scissors or cutters to be involved in this because the retina was very thin. Patient we did not want to create any further breaks in this patient. So one by one, all these epicenters are dissected. The membrane is removed. And you can see the post-operatively, again, the patient was fortunate enough to get a good vision of 6/9. So these are some techniques which can be helpful in managing these type of tough cases. I hope you will also try to follow some of these, include some of these techniques into your practice. Thank you.
Thank you, Sangeet sir, for those excellent videos. And as always, sir, I think your surgical videos, your recording, and the representation is, I think, just terrific, sir. Can I request all the presenters, please, everyone on the Zoom platform, humble request to please keep their mics on silent other than the time that they're speaking. A little bit of background noise coming from somebody. It's just a humble request, please. Thank you. Again, thank you, Sangeet, sir, for those wonderful videos.
Are we going to have a discussion now?
Absolutely.
I think that would be the better way of doing it. Isn't
Absolutely.
it, Nati? I think we'll
Yes,
discuss it now.
Yes, I think that it is a potpourri. So better to
Yes,
discuss
yes.
after each.
Yes. So, Sangeet, one of the major issue which you already, of course, partly dealt with was the intraoperative bleeding. Of course, you talked about giving pre-op. But what are the other means which you may have to use, as well as you have to be very careful while if you get into trouble of getting bleed intraoperatively? Because why I'm asking this is we all know, those who have been into this kind of surgery for a long time, that sometimes that bleed is a bigger monster than the basic disease there, because if we let it stay there for a longer time. So what are the things you would do or keep in mind? So this is my question to you.
Yes, sir. Sir, I think you have raised a very important concern that must be in the minds of many retinal surgeons, especially in these highly vascular membranes. A lot. So one thing is like the pre-operative, pre-operative anti-VEGF agent, the bleeding is less. Second, if the bleeding occurs, the first thing that comes in my mind is like to raise the bottle height, raise the infusion pressure, and sometimes I have to go even the infusion pressure. I have to raise the bottle height up to the diastolic blood pressure of the patient to control the bleeding. And if the raising the bottle height does not work, then the second step is to press the blood vessel that is bleeding with your light pipe. You can somehow applying pressure, you can control the blood. The next step will be to apply a cautery, and if nothing is working, I go bimanual with cautery in my left hand and the cutter in my right hand. And as soon as I just cut, and I'll just keep on cauterizing the blood vessels side by side. But that is the last thing. I think by these most of the times I am able to achieve a good hemostasis.
What about injecting anti-VEGF 2 days before vitrectomy?
Yes, sir, that is the first thing.
Okay. In spite of that, I know, I agree. Okay. So I think that's a good point. I think to take a message from your case. I mean, you're an excellent surgeon, but I think the way you did it is like cutting a cake. And I don't know whether any beginner shouldn't attempt it, because I think it's really beautiful. I mean, the way you do it, it looks like so simple in your hands. And I know you're an award winner and I think an excellent surgeon and probably a good teacher, or everybody should learn from your videos. So I think only caution to all the beginner surgeon, I'm not discouraging. And I think I'm telling them to start with simple cases and then go to manage the complicated cases like you do. Because what case you have done, and that took the beautiful result. I think out of the world result. I think I'm sure almost your cases are like that. But I remember in the 80s, the iatrogenic breaks were 20%. And I remember D. Juan telling in the stage, no, it happens. And John said, how can it happen? If you know how to do vitrectomy, it cannot happen. I think that's the point I think you're driving, but I think I want you to stress that. And the same question I think Mangat asked about hemorrhage. I think you should anticipate and prevent hemorrhage, because I think once you have a massive hemorrhage, sometimes it happens. And then it's actually, you can't do anything at that time and probably have to re-interfere. And sometimes people want to inject silicone oil immaturely during surgery because they can't remove the blood. And I think doing a good surgery and then silicone oil used only as a tamponer, or as in your case, I think I've seen it like looking like Stanley Chang operating. Thank you.
Thank you, sir. Thank you.
I think, Sangeet, what Nati has said is very right, and he has very nicely summed up few of the things. Few points which I would just like to say. One is, once you have a bleeding, don't ignore it. Tackle it that very moment. That is what we have seen. If we let it stay there, then we'll end up into a situation which Dr. Natarajan has already said, that we may have sometime a situation where it becomes into a mess and we inject the oil and we come back. So the question is, don't ignore that small bleed even. It will get stuck so badly, it will form a fibrin, and which will be worse than whatever your membranes are there. I think that's a very important point. And second issue which he raised is about the tamponade. You see, it has been my feeling all my life that if I don't use any tamponade, that case will be like what Sangeet said, 6-9. If no tamponade is required. And if you need just a gas, still that will do well. But if you have used oil, I think that's a bad call most of the time. In diabetic, I'm talking about diabetic complicated vitrectomy, because most of the time, I think in such cases, we have already had other issues. Maybe we have a break, we have not been able to tackle all the membranes, or so many other things. So I think what Sangeet mentioned, as well as Dr. Natarajan said, I think meticulous dissection of all the membranes, removal. If you have done it nicely, don't hasten and don't go for oil. That is my take for diabetic vitrectomies. I think diabetic vitrectomy, the oil is best avoided unless it is really, really necessary. That is my personal point of view, which I have over a period of time I've learned. I don't know. I would like hear Sangeet's comment.
So very well said, Mangat. And I think I remember meeting Miriam Bonet, who always called Jonovich as a Silikonovich, and he used to tell she actually, and he was a great that way, like a spiritual man. He was not spiritual, but what I meant is when people abused him, he took it well. But I think that's why he wrote a chapter called Abuse and Use and Abuse of Silicone Oil. I think that's what you're mentioning. I think people are in a hurry, and he was that time quoting the young surgeons in particularly in Italy and other places where if they can't do anything, they use oil. And I think that was not the thing. I think that's the lesson. I think the lesson is good vitrectomy, and then you choose the right tamponade, because sometimes the patients travel, and those times even I think it's better to have them oil and go. And there was actually once upon a time saying silicone oil prevents the VEGF coming from posterior segment to anterior segment. It's all temporary. But I think now with the VEGF era, I think the best is good dissection, and then you choose the tamponade wisely. At the same time, if you use silicone oil, be judicious, and that's what I think I will say. And I think the people have wrongly taken that any silicone oil means Jonovich said. He didn't say that, and that's why he used the word use and abuse of silicone oil.
Absolutely, sir. Very well put. I actually have one question to the panelists and also to Sangeet, sir. So this is a little bit of an extension of the topic that we had today. So any tips and tricks or any pointers, sir, for preventing or reducing the incidence of rebleeds post vitrectomy, which the incidence of which has gone down compared to the 20 gauge era, but it's still a problem that comes back to haunt us. So any tips or tricks to reduce the incidence during surgery, at the end of surgery? And what would be your indication, or how would you manage a rebleed? Would you re-inject? Would you wait? Would you do an office-based fluid air exchange? Would you go in and do a revitrectomy? What would be the way to go, sir? Sangeet, sir, if I can have your comments first, and then I'll go to the panelists, sir.
I think, Dr. Mohit, it depends. The rebleeds, one is the immediately you surgery, and one is it bleeds later, like 1 month or 2 months later or 3 months later, which is again due to different causes. So immediately after will sometimes, because the pressure, when you are removing your cannula, sometimes the pressure goes down, and all these your hemostasis that you have attained with cautery and all these vessels start bleeding again once the pressure goes down, and that is one of the main reasons. So one or two things, like during the surgery, what you can do is when I do laser, I reduce the infusion pressure. So when I reduce the infusion pressure to around 10 to 15, in between 10 to 15, so all the potential bleeders, they start bleeding I can cauterize them at that point. Secondly, when I make an incision, I almost go acute in the sutureless. So when we close that incisions, they seal properly rather than they remain open. So the third thing is in diabetic vitrectomies, especially, I'm not very fond of base dissection and retinal detachments as such, fresh retinal detachment. But for diabetic vitrectomies, I generally perform a full base dissection after vitrectomy and remove all the vitreous which is present at least near the ports, so that the later bleeding that can be due to the anterior hyaloid proliferation or due to the leakage or formation of membranes around posterior to sclerotomy sites, that do not happen. So these are few things that I take care of just to prevent these rebleeds.
Thank you, sir. Thank you.
I think some of the things which I would like to say here, one is, I think especially in a diabetic vitrectomy, don't be having that prestige that I'll not put a suture. In case little bit of a doubt you have, put a suture. you would be much better off. I can tell you that, because here the situation is different. Little bit of a hypotony, it's going to land into a mess. So it's not a big deal. So that is one thing I would like to mention here, is very important. Another issue is, if you have a very bad case, it has been oozing all throughout, and the surgery has been real challenge for you. I think you can inject at the end of surgery also. It's not only injecting pre-op. Here, in such a situation, I don't say in a routine, but you have a case where it has been oozing and it has been bad, I think you can do that at the end of surgery also, and it may also some way help and prevent. And what Mohit was asking about these office-based or those exchanges we used to do outside, I think those have gone, because now we have anti-VEGF, we have other things, and we also look at the status of retina and other things, and that's how we go with the post-operative, if you want to give an injection, or we want to hold on for some time, or what kind of approach. And if it is really perhaps happening recurrently and despite anti-VEGF, it has not cleared, then maybe we need to go in sometimes and then clear up again everything. And maybe there are some residual membrane, or there is one stump which is bleeding, or you have to do some more laser or other things. That is what may be required sometime in a rare situation. These are some of the points I wanted to add.
And Mohit, looks like I go back to history. Looks like I don't want to feel old, but the problem I think we have seen, we have done OPDFG exchanges for recurrent hemorrhages, and that was a big bugbear in 80 and the 80s to 90 was a big problem. So I have done several OPDFG where the patients used to bleed, and I think one of the things, as Dr. Mangat said, even 20-gauge sclerotomy closure was a problem. I remember in the first year of my vitrectomy, the closure was a challenge. And I think Dr. Badrinath will say close and go, and then you can't close it, airtight, watertight. And I think that's because the sclera was a problem operating for a few hours. And I think now we have come to small gauge. The reason I think Dr. Mangat said is no ego should be there, whether it's a diabetic or any case. I think the airtight, watertight, that's the advantage of a 3-port Parthena or whatever 4-port we are doing. And the other is, I think Sangeet mentioned, but I want to highlight that is during the surgery, lower the pressure and see that it doesn't bleed. For even it may, as I said, it takes time while doing the PRP. That's a good point. And when ooze happens, as Mangat said, make sure you increase the water light for temporarily. And then also, I have seen something like a blood stopper, heme stopper, Dr. Eckhart had made, used a blunt instrument. But I used to use the brush and keep pressing that oozer for some time, and it usually stops. And then you can also do a laser, but laser you may have to use a higher power, but best is to use a pinpoint bipolar diathermy. So I think you have to anticipate that it may bleed and do a thorough PRP, even if it is done good PRP before. And I think that's why I said the case was a beautiful case after he has done excellent, except the disc and macula, everything was ablated. And I think it's beautiful. And I think follow-ups are important. And I'm seeing, suddenly I'm remembering the last 35 years of vitrectomy. And nowadays, I think I don't see a patient, and I don't even remembering seeing a recurrent hemorrhage. I think that's because of the anti-VEGF, good laser. And I think the next month I'm planning as being the diabetic thing. I want to start from November 1st. Every day should be a diabetic eye care day. That means diabetic eye care month on November 14th is World Diabetes Day. And we have 77 million diabetic. If you treat them, and like the US, and they will say complicated case, but actually it won't be complicated like what we see here in India and Mexico and Africa. And I think that's because they treat early, they do multiple injections and lasers. And I think we can definitely fight with the diabetic blindness.
No, I have a question. Is there any role of, at closure, if you have an extensive dissection that you've done, any role of anti-VEGF at closure of the surgery that can help you prevent the recurrent bleeding?
If the patient has had no anti-VEGF, and then, for example, you didn't plan an anti-VEGF and it was a vitreous hemorrhage and there was a TRD, and you think that it's almost like a cold case, and on the table you see active vascularization, you remove all the fibrous tissue, then I inject anti-VEGF. Because if you leave a fibrous tissue and inject, and it will contract.
Any role of, sir, one more question, any role of cryo to the ports at the end of the surgery in diabetic cases?
But nowadays, because of the 3-port, like the 23 or 25 gauge, usually you don't have that fibrovascular proliferation at the sclerotomy. Usually when you're doing 20 gauge and a suturing, then you have this problem, because one of the recurrent hemorrhages were because of the proliferation at the sclerotomy side. We have seen sometimes an excellent PRP and the patient will bleed. And we don't know, and we go inside, we do vitreous lavage, and the surgery will go in 2-3 minutes. By the time we put the infusion and open the second sclerotomy and third sclerotomy, they are already washed out. You wonder why you operated. But I think that's because of the bleed from the sclerotomy side, and that's because of the 20 gauge and prolonged surgery, I think. And that's why you have to do a meticulous surgery. Keep this in mind. And the cryo is, I think, it's almost gone, except the reason is, I think, cryo damages all layers of the eye, right from if you're a full thickness, I think, if you go in, why do you want to do that? And nowadays we can do with a depression or a curved laser probe, 360-degree all around.
Absolutely, sir. I think great point, sir. Thank you, sir, Dr. Natarajan and Dr. Mangat. With that, we'll move to Dr. Natarajan sir's talk with sir's permission. And we all know the stellar work that sir's been doing for a lot of years in Kashmir. And the sir's going to speak to us and share his experience with us on pellet ocular trauma. And needless to say, it's the largest series in the world. Dr. Natarajan, sir, please.
Thank you, Mohit, and thank you, Anil and Ajanta Pharma for the. I'm sharing the screen. So the pellet ocular trauma, and it's unfortunate to be a part of the world's largest series, but I think it was needed to go there to help them, and I don't have any financial interest. And this was happened in between June and November 2016, a white protest, and all of us know this. And then this happened in the Sri Maharaja Hari Singh Hospital at tertiary healthcare. And I wanted to say that thanks to Professor Tariq Qureshi, the head of the department, and Dr. Sabia, trained in Amritsar, and Dr. I forgot his name now. The one trained in the Arvind Hospital, and they have all the subspecialties. But in spite of that, I think they need a moral support, and they're all good surgeons. And you can imagine there's thousands of surgeries. They have done the wound repair, and that's why I could do the secondary surgery there, and hundreds of detachments and macular injuries, awaiting with faith in humanity and trust in the Almighty behind that call. And the patients were between the average was 22 years, 73% had open globe and 22% closed globe injuries, 93% monocular, fortunately, 5% binocular, and 86.7% had lost vision to less than counting fingers or worse. And they being among the best and most experienced, not me who will. And that's the reason I went. This is a glimpse into the sphere of the cases. This is a 23 gauge being done in a phakic eye. One of the challenge was there was no PVD. And I think, I don't know what happens when the pellet goes, there's no PVD happening. So that was a challenge. And here you see the total vitrectomy being done. And you can see, looks like there's a pellet there in the near the macula, but actually that was a site of the pellet, I think probably hit and then fell down inferiorly. Or sometimes it goes through and through, and then it's not inside the eye. And here you can see I am using the 4-pronged forceps, actually designed by Dr. Mahesh Shanmugam and Dr. Manish Papai, and myself. We actually, he designed it, and I used it. Made, I don't have any financial interest. Made by the again, forgetting the company name. So which we use for removing the pellets. And the whole, again, as we mentioned in the previous diabetic retinopathy, I think we have to do a thorough vitreous dissection, make sure as much as possible vitreous basic excision is done. And then here you see the site of impact, and then the entire vitreous is being cleared. And I see there is a foreign body in the inferiorly, and that's the time I decide not to remove the pellet from within the vitreous hemorrhage, and I'm grasping it along with the hemorrhage and teasing it with the light pipe, where there is a forceps designed by Manish Papai, where the pellet is about 4 into 4, and you can see the vitreous hemorrhage coming, and then you can, this was 11 to 1 o'clock, I made a conjunctival incision, scleral incision, and then removed it. And you can see some heme on the surface, but I think a phakic eye, and I like to leave the eye phakic. You close the scleral wound and the conjunctival wound and proceed with the 3-port vitrectomy to complete the vitrectomy, and also do endolaser around the site of impact. And this was periphery. Fortunately, there was no trauma to the retina. And patients, when the macula was all right, the patient's vision does well. And this is another eye where so you can see again a 3/4 pars plana vitrectomy being done and clearing the vitreous hemorrhage. And the whole thing is you can see these sort of eyes when the macula is all right, disc is all right, and I'm trying to induce the PVD and clear all the vitreous. So I think that's the most important, and so that you can leave an eye quiet, and then also you don't have the risk of recurrent or a regmatous retinal detachment following vitrectomy. And again, you see the periphery being cleared, and then most of the vitreous is cleared from here. And then in the periphery, where you'll see the impact site, I usually do a laser, like almost making it like a coloboma choroid. That means do laser around the site of impact, because or there is a site of where the exit wound is there. That means a double perforation has happened. And these sort of eyes, when the disc and macula are okay, most of them get good vision. But sometimes when the pellet has gone through center of cornea, center of lens, and center of macula, then the vision is a problem. But I think that was a problem where the Dr. Tariq Qureshi and the other consultants in Sri Maharaja Harising Hospital faced is people were asking, will every patient get vision, or whether they'll all go blind, why this is happening and all that. So I told them, I've come as so you can see the subretinal hemorrhage in the extreme periphery. These sort of subretinal hemorrhages away from the disc and macula, you can leave it behind, but clear the vitreous. And as I said, there was an exit wound, did the endo laser around that and created like a coloboma choroid, so that even there's a break within that, you actually barricaded it. And this is just to say, this is a 20 gauge vitrectomy being done. This is actually done in 92 when there was a boy and a small 5-year-old boy playing with a 6-year-old sister, and they had a head-on with a toy gun. They made used the toy gun, and then there was there was a bullet which was like made of aluminum, not the real bullet. If the real bullet, the child would have died. And you can see I'm actually, to prevent hemorrhage, I'm filling the eye with the air, and then I'll make a slit of the corneal incision and coat the posterior surface of the cornea with the viscoelastic, and then remove this aluminum bullet, and which is like almost 10 millimeters, and you can see like an arrow shape which is gone. And I think this child needed a second surgery. And I'm showing this because I think I have a passion for repairing ocular trauma. I've seen from my childhood days my father doing it, and then later Dr. Badrinath, and then so that's how I do mostly every OT case. I have a trauma case, and probably that's the reason they called me to help in Kashmir, and I did that. So this is, I just want to demonstrate that I mean, apart from the pellet ocular trauma, that I also operated some of the trauma patients there, which happened in domestic trauma, and then something like this, where you're now seeing the eyes filled with air, because otherwise the bleeding was not stopping, continuous ooze was there, view was not seen, and continuous air was going, and through that I'm now using I didn't have the diamond blade, but I used the regular blade, and then removing the pellet and holding the bullet in one hand through the pars plana, and then using the regular forceps and removing it through the corneal incision. And then you close the corneal wound and then do a thorough vitrectomy. And then these sort of eyes may need multiple surgeries. So that's what I wanted to say, not to give up. And then this is the other eye. This was a corneal, you can see the corneal wound. And this patient came in a week's time to Mumbai. And after that, I told them, never come to travel. I'll come to Kashmir and operate. And I recommend that after the immediate injury, within a week, we should do the second surgery. And that's what Ferenc Kuhn, as the president of International Society of Ocular Trauma, recommends. And I also recommend second surgery should be done between 6 and 8 days as a second window. And here I have the advantage of Dr. Kavita Rao doing the cataract phaco extraction and putting the lens. And I'm then going ahead with a 23 gauge. and then there was vitreous hemorrhage. After clearing the vitreous hemorrhage, I see submacular hemorrhage. So I do a 39 gauge retinotomy, and it was only 6 or 7 days old. So I could drain the submacular hemorrhage through that small retinotomy, and I do a endo laser around that retinotomy, and then I use silicone oil as a tamponade, and then remove the silicone oil at the end of 3 months. And then you can see the patient got about he had a counting finger close to face, and then post surgery had about counting finger 3 meter, and that's because of the corneal astigmatism, which can be corrected later. And I generally recommend that we should do, and that's what I encouraged all the patients, that don't expect a miracle surgery in one surgery. And I said it's our duty to repair and let Allah give the vision. And fortunately, I have guts to face them, and I face the press as well as the patients and their relatives, and their wards were full. And this is again, you can see the corneal suture, where and then a cataract there, and then I think I do a lensectomy and vitrectomy. And these sort of patients, I think better not to have an IOL. We can do a secondary IOL where in the secondary, and I do a lensectomy because it's a totally traumatic cataract, soft cataract all around in the antechamber with a total vitreous hemorrhage. You clear the vitreous hemorrhage like when, and I should congratulate the government of Kashmir and Sri Maharaja Hari Singh Hospital, the dean, and the head of the department, our ophthalmologist, Dr. Tariq Qureshi, for having the operation theater well equipped. I think a fantastic operation theater with the Alcon constellation, the biome, and I think the Zeiss also was helpful that time. The biome didn't work, but I made sure they have everything. And I recommended that they should have a center of excellence there for trauma management, not only for palatal trauma, for north of Delhi and north of Chandigarh. I think if they have a center in Srinagar, I think they can at least do all the repairs there itself, because they're all well equipped. They have cornea trained fellows, retina trained, oculoplasty, and everything there. And I think they can be self-sufficient, and people like us can go now and then to teach them. And I love to do that, and that's why I did about almost 5 months. You can see the lensectomy, vitrectomy, and then I was quiet. So the outcome from our team is the toughest times. This is an analysis done in about 601. Totally 1,011 we did in the 5 months, and 88% on the same day wound repair was done, and 10.6% within the next 24 hours. Sometimes hundreds of wound repairs were done. That's why I wanted to congratulate the meticulous wound repair done by the resident to the chair, the head of the department. I think it's a teamwork. 130 patients coming with the pellet in one shot, and then starting at 8 in the morning, goes on till midnight. And same vitrectomies I did from morning to midnight. And post-operatively, after multiple surgery in each visit, over the span of almost half a year of battle, and 17.6% gain, 6/60 or better, and 82.4% gain visual acuity of counting finger close to face. And that's the problem of injuries. But I think nevertheless, if you don't operate, and I think I recommend surgery, because if you don't operate, even this counting finger in the fellow eye, I think can be a stepney, because they are all 20-year-old, and we expect them to live 80 to 100 years. That means 60 to 80 years of productive time in their life. And at least they will be living as one and a half eyed, not one eyed. And I had 3 or 4 patients where they, in 2010 pellet trauma, they lost one eye, and they come with the other eye being lost in the pellet ocular trauma. And that's the psychology of the people. But at least by doing this, we wanted to say, I felt like that seeing the Second World War movie, where you see the Red Cross, the nurse and the doctor carrying in stretcher during the bombing happening. And that's the same feeling I had when I went to Kashmir. And that's the team I took in the first visit to Dr. Kenshuk from Delhi and Dr. Harshad from, they both are my fellows, they are consultants now. And Dr. Syed Harshad is working in Uganda as a consultant, and Dr. Kenshuk is working in Fortis Hospital, Delhi. And thanks to the team, and we see Dr. Tariq Qureshi, the Borderless World Foundation, who took me every time. And I didn't have any security. And I think this is what I want to tell all the young people: never fear anything. And that's why I faced the TV. I faced, and I think especially recognizing our daredevils, Dr. Tariq Qureshi, Dr. Syed Asghar and Dr. Kanship Marwa. Thank you very much for the opportunity to share my experience.
Thank you, sir. Thank you, Natarajan, sir, for that excellent talk as always, sir, and the stellar work that you and the entire team has done, sir. I think we can't even begin to imagine the kind of the trauma the patients had to go through, and the long hours that you and your team had to put in, sir, to go through all of that. I don't think questions are in order after this, but I will still try and play devil's advocate and first have Dr. Mangat Dogra's comments on the series of surgeries that Dr. Natarajan sir just showed regarding peritocular trauma, and any tips or tricks or any caveats that he would like to share with people who would be starting out, because these pellets can be very resistant to so-called being removed from the eye, unlike other metallic hammer and chisel injuries. So anything that Dr. Dogra would like to add?
First of all, I would like to congratulate Professor Natarajan for doing such a great job. We feel so proud in Vichu Retina fraternity about his work. And this is entirely also humanitarian, because in such a situation where you have so many young people and they are losing, and you kind of provided such a great hope for them, not of hope, but you practically did it. So I think you deserve a lot of credit for that, Dr. Natarajan, and it's a great job done. Absolutely. We feel really humbled. And I would like to say these are the real challenging cases. These cases, sometimes some of these cases would drop to us in Chandigarh, you see, because Chandigarh is still in the proximity. But our problem was with most cases which I had seen, they were coming to us late. I think you could tackle them early. And you already made that point. I think if we are late, I think we go back to Stephen Ryan's work, which is like a landmark which he did, that there is an intraocular fibrosis. If there is a vitreous hemorrhage and a posterior penetrating trauma, and if it is a double perforation, then it is a severe intraocular fibrosis. Intraocular fibrosis means nothing can be done at that stage because it can't be cut with anything, and most of the battle is lost. So that is where perhaps we saw these cases coming very late in few months' time, and we could, of course, salvage some of them, but was a problem. So I think the timing, which Dr. Natarajan has very nicely said, and he talked about it within a week or so, that maybe we should tackle them in 6 to 10 days after doing a good. And I must congratulate Dr. Tariq. I have known also him very well, that they did primary repair for 88% immediately. You see, that was a very high point. I think that's another one which probably did save some of these eyes. But you see, these are challenges, other challenges which perhaps Rajan has not. Sometimes these are multiple pellets. They are all over. They are everywhere. They may be lodged in so many places that you can't chase each and everything in them. And the problem is also having other issues which are related with such injuries. So I think what he has shown, has done, is remarkable. We need to intervene early, but these are same like BB injuries, which we know in Western world. They thought if there is a BB injury, most of the time the eye is lost. And that is what basically these are the most challenging cases. And I think only thing is that we have to go early, but otherwise also somehow I think if we can have some preventive thing, because Professor Natarajan is here, he's on the international scene as far as the ocular trauma is concerned. He's been involved. I think we should have something which should be preventing this. I think in such a situation, prevention is much better than what we can offer as a cure. I think that is what need to be emphasized, and we need to come up with something like that.
So thank you, Mangat. And I think, Mohit, with your permission, I just want to add one. Recently, the rubber bullet injury happened in July after Clive Lloyd was killed in US. And then they used rubber bullet. And so happened, In 2016 August, New York Times covered me in the front page, and they re-quote the president of American Academy quoted that. And Academy came down very openly and forcefully against the federal government. I won't say against, and advocated to the government that you should not use rubber bullets for chasing away the thing. And in India, we are still not able to do that. And unfortunately, I don't want to talk, but I'm telling in the webinar here, and that was the problem I faced in the press. As you rightly said, we should advocate prevention. So I will take this opportunity as a past president of All India and as a past president of Ocular Trauma Society. I am actually moving in both AOS and OTSI and public interest litigation on at least cracker injury, which is coming now. Diwali is coming, and I actually want to bring a PIL to ban cracker. I know one of the, because Sivagasi is a town next to my hometown, my grandmother's hometown, where they make the crackers, and they told me that they are like the dons of, they are one of the richest people, and they will come after you. I said, what else can be there? I remember in Kashmir, Dr. Kande is there. He mentioned to me one day suddenly, because there were a lot of Middle East TVs were there, and then did a lot of interviews in every visit. And then the doctors in the government hospital was always a problem where they don't know what to answer because they're government servants. Luckily I'm a private, and I was at that time, I think president-elect, I think, or a vice president, I don't know, nothing. I was probably editor of Indian Journal. Anyway, so I was an office bearer of All India. So I think, and plus a private, I could talk anything I want, and there was no restriction. I demanded to meet the chief minister. I demanded to meet the chief secretary. And I told them we should do something where, because there was a problem there between civil, police, and the army. And then it's a real, a very sticky situation. Same thing happened in US also. I think if you have seen, there's no publication coming. Even mine was rejected 3-4 times, and Tariq is a little upset. 4 years we are struggling to publish. There's some problem going on. And at least in New York Times it's covered. So this is again covered in 2019. It happened in Chile. So I think world over, as an ophthalmic society, we have to say, please do something. When you disperse crowd, don't make normal people blind. And I think that's what will be a plea rather than fighting. And during cracker injury, I want to say we should ban. What is the use of? I'm a Hindu, so nobody can make an issue that like you just mentioned about Navaratri, and I'm a spiritual person. I'm a religious person. I follow all the rituals, and I think cracker was against Nargasura, who was a demon. So I said you can do virtual now. We are doing all virtual conferences. Why not do virtual crackers? Virtual, make a fatakada in the house, you put a blast sound and make all the things, and then have flower pots also in the big giant screen if you're a rich person. Ordinary person can see in the mobile, and what else you want. So I think this is what I think we should convey. Trauma should be prevented, because I always say as ophthalmologists, we have diabetic disease to treat, ARMD to treat, and so many diseases to treat which you can't prevent. And at least you can prevent blindness, but the disease can happen. But trauma can be zero. Why not we do it? I know it's a very spiritual thing I'm asking, but we have to take measures and do advocacy, which I think every society should do. Maybe even a state society should take it up with every state, because health is a state subject, and make an issue with the health ministry during cracker and it's prevented. And then when this happens, issue a statement that people are going blind, that too young people going blind, and even if making them one-eyed is not fair.
I think you touched a very right point. One of the things which we should learn from the Western countries is, if we can have these crackers being handled by professionals at designated places, let it be in 10, 20, 30 places if it's a big city or in a small place. And then they also celebrate it all the time. They do it on multiple occasions. I think if we have that kind of thing, that way cracker industry will not also totally close, but we have professional handling it, and there are no injuries. I think that's where we should go. Here, the maximum handling of cracker is by children, and we see so much of devastating injuries during. So you touched a very, very important point, and that is another area. I think if you emphasize that they can at least do it at a common place somewhere, maybe whatever way we can say sector-wise, or they do whatever area-wise, and that will be fine, handled by some professional people. Let everybody collect there and celebrate. So this was another thing I wanted to just pass on to you, if you can sort of
Yes.
put that. Maybe
Sure.
this will not, if they don't agree for total ban, at least they'll.
Yes, yes. Now ask for a total ban and settle for this.
Yes, yes, yes.
Absolutely great thoughts, Natarajan sir and Dogra sir. I'll just like to bring Dr. Sangeet Mittal into this also and and want to ask his experience, because he also deals with his fair share of ocular trauma patients, and he's also someone who does chorioretinectomies for some of these penetrating injuries, as has been advocated by Dr. Ferenc Kuhn. So, Dr. Sangeet, what is your take on chorioretinectomies for double perforations or penetrating ocular trauma, and what would be your indications or precautions for people who would like to do it?
Thank you, Mohit. I think Dr. Natarajan has done a very commendable job. I don't have words to describe this, but it is very inspiring. I think he inspires so many young retina surgeons all over India with this type of works. Uh, chorioretinectomy, I've been doing for past some time now for this double perforations or very deep impact trauma, and it works very well, especially if the foreign body is impacted close to the macula. What happens is, like, when the foreign body is removed and the PVR changes occur at the exit wound, and those membranes, they develop over the macula, and it's very difficult to I've been doing cases. I've removed these epiretinal membranes 3-4 times, and again they will grow over the macula and they form. So chorioretinectomy is one technique which can prevent this PVR which is happening in the posterior pole. What you do is, like, you make 100% diathermy burns around the exit wound to the retina and the choroid, and you have to melt the retina and the choroid with the diathermy, and if it is not possible, you can even use your cutter to remove the choroid and the retina from that wound site, and it settles very nicely. I don't remember any case developing PVR after doing a chorioretinectomy in this fashion. One thing I'd like to ask Dr. Rajan, because I faced such a peculiar situation in this one patient that came to me with this pellet trauma. He had a through and through injury, and the bullet had gone behind the eye. When I started vitrectomy, the infusion that I put in, it was all leaking behind the eye, and I could not do anything. Any, sir, comments on?
Usually, that's why I do that the exit wound vitrectomy area last, because if you do that, then the wound can keep leaking. So I think most of the eyes when I saw that, I did that exit wound vitrectomy last. So fortunately, I think I didn't have any of them. I remember long time back, I had a patient like this. I injected oil and the oil was going through that. Then I decided that it should not use force, and then probably did a fluid air exchange and make sure that when the oil was going, I didn't increase the intraocular pressure so that the oil did not go. And if you have seen in the nature helps us, if you make sure meticulously do vitrectomy there and then make sure you don't have a leak, and then usually it heals well. So if you try going and suturing outside, that is also going to collapse the eye. So I think the one is the way that a vitreous removal from that area should be done last. Otherwise, I think this particular problem will be there, because even put PFCL, it will go through that.
Absolutely, sir. I think points taken. There are no further, comments from the panelists or the presenters. I'd like to invite Dr. Amandeep Singh. Dr. Ajay Arora, who was scheduled for his talk now, is actually caught up in the OR. There was an emergency that someone from his hospital where he works had a urgent eye condition that needed to be surgically intervened. So he has messaged, and I think should be able to join us maybe towards the end of the webinar. So we'll be, just skipping on to Dr. Amandeep Singh, who's kindly consented to have his talk earlier. Dr. Amandeep Singh is assistant professor at the Punjab Institute of Medical Sciences in Jalandhar, and is also the medical director of Aurora Eye Hospital and Retina Center at Jalandhar. He's going to be speaking. We're going to, since it's Retina Potpourri, we're going to be switching, kind of lanes and going on to pediatric retina, and of which the leading cause of childhood blindness is pediatric retinal disorders, of which ROP unfortunately tops the list. So he's going to be talking to us on anti-VEGF injections in ROP. Dr. Amandeep Singh, please.
Okay, I'll just start with the slide share.
Please.
Just 1 second. I think it is on.
Uh,
Is it audible to everybody? It's on.
Absolutely, absolutely, Dr. Amandeep, it is.
So it's first of all, I am very thankful to Ajanta Pharma, and it's an honor to be with Dr. Natarajan, Dr. Mangat Dogra, Dr. Sangeet, and all other senior veterinary surgeon. So I'll be talking about anti-VEGF and ROP. So first, I'll just talk about retinopathy of prematurity a little bit. Then I'll go. As we all know that normal pregnancy ranges from is 38 to 42 weeks, and full-term infant weighs around 25 to 4,000 grams. Preterm is defined as babies who are born before 37 weeks of pregnancy. And premature babies, they have not many other complications, and ROP is also one of them. Complications usually depend on how early the infant is born. So it's a retinopathy of prematurity is a vasoproliferative disorder of the retina of the premature infant. The screening, treatment, and pathophysiological understanding of ROP has dramatically evolved over last 4 decades. As we go for global epidemiology of ROP, ROP is one of the most common cause of avoidable blindness in children. Around of 15 million babies born preterm, 15 to 20% are affected by ROP, and out of which approximately around 20 to 40,000 of infants worldwide go blind because of ROP every year. And India, there is another pandemic. It's a third pandemic which we are having as an ROP. And of 3.5 million premature births in India, 6 lakh children are born less than 32 years of gestation age, 32 weeks of gestation age, and out of which 40% receive neonatal care, and out of which 80% of them survive. So approximately 2 lakh infants, if we see, have chances to develop ROP in India itself. So this is just a demographic, geographic representation of visual impairments from ROP all over the world. And so we all know that major risk factors for development of ROP is hypoxemia, post-natal oxygen supply, hyperglycemia, neonatal infection, hypercarbia, low gestational age, low birth weight less than 1500 grams, low postnatal weight gain is also one of the reasons. So this is just a slide showing that how ROP develops as the premature birth takes place. There's a down regulation of VEGF, and as hypoxic retina again start producing VEGF, this leads to formation of new blood vessels and formation of ROP develops in the baby. So screening should be done for all the babies who are less than 200 grams, gestational age less than 34 weeks, and it should be also be done for babies who are born between 34 to 36 weeks if there are risk factors like blood transfusion, fetal hemorrhage, exchange transfusion, neonatal sepsis, or if the neonatologists feel that they should be screening done, it should be screened. Timing of screening is like we know that it's within after the after the birth, 4 weeks after the birth of a baby, and if the gestational age is less than 28 weeks, or if the baby's weight is less than 1200 gram, then it should be done within first 2 to 3 weeks to prevent to detect AP-ROP in these babies. There are 2 landmark studies in ROP, that is cryo-ROP, ET-ROP. These are the were the stepping stone for establishing treatment guidelines, and also defining threshold ROP and type 1 ROP. So coming to management criteria, type 1 ROP, we need to treat them early within 48 hours, and type 2 ROP, we can watch for some time and observe if it develops or it regresses or it goes progresses further. Cryotherapy is not at all done these days. Laser therapy is still a current standard of care for treatment of ROP, and it has got very less adverse effect as compared to cryotherapy. Though it's a destructive procedure, patients have tunnel vision, high incidence of myopia, babies can develop exudative retinal detachment. Surgery is only indicated in cases of stage 4 or stage 5 RP. And coming to anti-VEGF in ROP, and indication for giving an anti-VEGF injection in ROP if there's a non-dilating or rigid pupil in babies who have AP-ROP or babies who are very sick which cannot be treated. Worsening despite of laser is another indication. Large pre-retinal hemorrhage or vitreous hemorrhage or media, hazy media, we can go for a injection of anti-VEGF. Or there's a lack of expertise in doing laser, or if your suddenly laser is out of order, we can still, to salvage the vision, we can give an injection. Dosage and technique, usually there's a lot of controversy about amount of dose to be given in these infants, and I usually prefer a half of the adult dose, whether it's a bevacizumab or ranibizumab. Parental consent is very important, and these procedures are preferred to be done in a OT itself, but can be done in NSU, taking all sterile precautions. And site of injection is 1 to 1.5 millimeter behind the limbus, but while injecting, needle should be directed more posteriorly rather perpendicular to the sclera. And giving bilateral injection is controversial, but if it's a need, then one can go ahead with that. Why anti-VEGF is now more popular? Because it's a brief and it's a 5 minute procedure. It's less stressful for the surgeon and also for the baby. It has got quick and dramatic effects. Regression is noted with a single injection. There's no effect on the visual field of the infant, and promotes normal development of the retina. There are various phases with it has been defined that how VEGF acts in this thing. The first stage is a rapid stage of quietening. When we give an injection, there's a sudden quietening of everything. Everything seems to be normal. Then there's a slow vascular development, which lasts up to 11 weeks. Slow vascular development is due to VEGF secretion from a vascular return or from other factors which are not blocked. And then there's a third phase, that is a phase of regression, which is up to 16 weeks. We see most of the patients like they develop a ridge like a classic ROP, and this may regress completely on a follow-up, or it can go or rebound up also, depending on the factors which are various ocular, systemic, or unknown factors. Considering the two injections, there are other injections also available like aflibercept or brolucizumab, but most commonly on the literature, these two are more used. And comparing these two, the only bad point about bevacizumab is that it's got a very large systemic half-life, that is 7 to 21 days, whereas ranibizumab has only 3 days. So as we all know that these infants, VEGF is required for the growth of the lungs, kidneys, and the brain itself. So suppression of the VEGF elsewhere systemically can have harmful effect over the infant growth overall. There's a various publications on effects on the developing retinal vasculature of the VEGF itself, like post-VEGF injection, anomalous circumferential vessels have been reported, vascular loops, and short-root shunts, or abnormal AFZ. These have been noted on mainly because on the fluorescein angiography, and what effect these have in the future is nobody knows that answer right now. Coming to major landmark studies in ROP, there are more than 1,000 articles published over use of anti-VEGF in ROP, but most of them are retrospective and they are non-randomized. And if you look at one of the article, that is BEAT ROP study, this is a randomized trial, multi-central trial, and BEAT ROP study demonstrated that Bevimizumab had a significant beneficial effect in zone 1 ROP, but not in zone 2 ROP disease. Similarly, CARE ROP study was also a randomized multicenter trial, which was supported by Novartis company. And it was to investigate two different doses of ranibizumab in ROP, that is 0.12 milligram versus 0.20 milligram. This study demonstrated that ranibizumab is effective in controlling acute ROP, and 24% of the standard adult dose, that is 0.12 milligram, appears to be equally effective as 40% dose, that is 0.2 milligram. Then the recent trial is a Rainbow trial. Rainbow trial compared ranibizumab with laser therapy for treatment of ROP. It's also a randomized multi-center open label trial with 3 parallel arms with ranibizumab 2 milligram, 0.1 milligram, and laser. The endpoint primary and objective was to demonstrate ranibizumab 2.2 milligram had superior efficacy to laser as measured by treatment success. Treatment success was defined as absence of active ROP or absence of unfavorable structural outcomes at 24 weeks. The secondary objectives were ranibizumab 0.5 milligram had superior efficacy to laser, or ranibizumab 0.2 milligram had superior efficacy to 0.1 milligram. So coming to endpoints, 80% of infants treated with ranibizumab 0.2 milligram were twice likely to achieve treatment success versus laser. And primary outcome, 80% of infants achieved success treatment with ranibizumab 0.2 milligram. And one more thing was noted was unfavorable sexual outcomes were lowest in the ranibizumab 0.2 milligram treatment groups compared to other two arms. Coming to conclusion that that ranibizumab 0.2 milligram was much more superior, and it is much more efficacious, 80% more efficacious than laser itself. Side effects were not more than the laser group itself. And this is the first study to report pharmacokinetics and systemic VEGF data. 5 were extension studies currently going on. Coming to practically complications of anti-VEGF injection is that recurrence that has been reported in 0 to 83% in various studies. So long-term follow-up is required in these patients who are only given anti-VEGF injections. Subconjunctival hemorrhage, cataract, retinal detachment, endophthalmitis. If a preterm baby develops an infant develops an endophthalmitis, it's a life-threatening and it's a challenging situation. Effect of anti-VEGF on infants' brain, kidneys, and lungs are still not very clear at the present stage. Rate of recurrence of ROP after treatment with this is just a chart that shows rate of recurrence of ROP comparing ranibizumab versus bevacizumab. And ranibizumab has a higher rate of recurrence, around 16 to 83%, where recurrence of patient with bevacizumab range from 0 to 10%. Probably reason being is larger systemic half-life of bevacizumab in as compared to ranibizumab. There's another study by Morin et al. In which the odds of having severe neuroretinal development disability like cerebral palsy, hearing aids, or bilateral blindness was 3 times more with bevacizumab rather than with the laser treatment. But this was a retrospective study and non-randomized, and only sick infants were given bevacizumab. The timing of injection is also very important in these patients. The optimal time is the earliest sign when we see there's a plus disease or a neovascularization, and it should be avoided in late stage 4 or 5, due to contraction of the fibrovascular membranes and posterior halide, which can occur if there's a already fibrosis has started taking place and can lead to fractional retinal detachment. Conclusion: anti-VEGF, though it's a very good option, is a good option versus laser, but there are so many things that we have to think before we give it. The amount of dosage, that is a right amount for a preterm infant, long-term safety, efficacy, recurrence of the disease, and financial accept and financial aspect and long-term follow-up in India is a big question mark for shifting from laser to anti-VEGF therapy purely in India. Thank you, sir.
Thank you, Dr. Amandeep. That was for that exhaustive review, and actually, made us aware of most of the printed data on the role and the use and the outcomes of anti-VEGF for ROP. And without further ado, I would like to go straight to Dr. Mangal Dogra for his comments. I think we can't have anyone better than him to share his experience and his caveats for people who would so basically questions like indications, current indications for anti-VEGF in ROP. What would he consider as relative or absolute contraindications for injections? What are the precautions? Any surgical tips as opposed to how to give these injections as opposed to how you give them in adults? So Dr. Dogra, please.
Thank you, Amandeep, for a very good not only overview, but going into all the aspects. You talked about everything which are both the positives and negatives which are there, and you discussed each and every point very well. Well, anti-VEGFs are getting more acceptance as far as the ROP is concerned. I am saying that. But you see, the question is, most of the time, it should be used in cases like a zone 1 ROP or a AP ROP. Why? Because I would come to that because you see, Rainbow trial, the biggest problem was the success rate which they mentioned, 66% of laser is absolutely abysmal. That means these people were absolutely novices. They were not knowing how to do laser. I can tell you that because that's not the result. These days, the laser does very well in 90%. So that is, laser is individual dependent. So if it is done the way I have seen all my life, the way people do it half-hearted, it doesn't work. So that's why perhaps there is a difference in the result. And of course, definitely no denying the fact that it works very well. But there is a problem. Now this is being used as a substitute. Even in any case, they will see any stage of ROP, give injection. That is a problem. You see, without even waiting for the indication. And not only one injection, sometimes even second injection being given after some time. But there are issues. You already mentioned about those things earlier also. That one is high rate of recurrences which happen in them. And second is, which is very, very important, some of them may not get vascularized retina ever. They may remain avascular for life. And then how do you follow these children? This is the biggest challenge we were facing in PGI when I was there, that the child is growing, the retina is not getting vascularized. Now, you can't even examine such a infant because he has grown now big. He'll resist. He'll not allow to. So you need an examination under anesthesia. And many a times, and you find that it might start behaving like a familial exudative vitreoretinopathy because it is not going back at all. So I think what I want to say is that perhaps at this time, if we use it judiciously, it uses very good in zone 1 ROP, in AP ROP, and we follow these cases. Some of them may require additional laser because if they tend to recur back, then, and second is, I think whenever you already mentioned about that crunch phenomena, if there is already a proliferation happening and it is significant and it is getting raised, if you use in these cases, we might have an issue. If the retina gets crunched, it will straight away go into absolute problem and maybe stage 5. So I think we have to be very careful, but not to use as a substitute to the laser and non-availability of ophthalmologists. In a remote area and many areas, people are injecting left and right, because after, especially, I must say, even this rainbow trial, they got even much more bigger license to inject left and right. So this is something like anti-VEGFs anywhere. So that perhaps we need to, and you already mentioned about the safety issues. I mentioned about uh, these retina not getting vascularized or recurrence is happening. So I think we have to have a judicious use. Use it, and it is effective, no doubt, but we should not be using in every case. I think for that we need more evidence to come, and they need to have a better trial for that kind of evidence to come, that where we can use in every case. Because what happens to these retinas which are not getting vascularized subsequently, we don't know. And what happens if the recurrences are happening late? They have mentioned, they have reported a case where the recurrence has happened after 2.5 years. So then what do? You see that those are the issues we should keep in mind. But otherwise, it's a very good treatment. But I would still say laser is still a finite treatment. What is good with the laser? Once laser has worked and the disease has regressed, it is never going to come back. It is a finite treatment. It's not like anti-VEGF that it can come back anytime. So that's the point I'm raising here. But in most of the cases where you have a severe disease, you have to use anti-VEGF. You may need a combination treatment, and that is how we have to go about it to have a better success. And keep in mind all those systemic and other issues which we are not knowing at this time. You already mentioned about the dosages and other things which still we are sort of not knowing that much. But well, you also mentioned about bilateral injections. I think most of the time in babies, we have to do these bilateral injections because disease is similar. Or you can maximum postpone by a day or two. It doesn't work that way. So if we take full precautions, I think this is one area where we have to give injection in both eyes most of the time, the same day, but with full, like separate. It is just like even in ROP is one area they are doing bilateral sequential simultaneous surgeries for both eyes, especially in cases of stage 4A, 4B. Because the reason is this only, because they may not give another chance for anesthesia, it's high risk, and one may have to do both eyes, but as an independent. You go independently and do with all the precautions as a separate case, not that same thing or same syringe you use, then it may be a problem. So these are some of the things which I wanted to mention. I'm open also to any of the questions if there are from our other speakers here, as well as Amandeep, if he would like to mention anything. And Sangeet also does. I think everywhere here, if there are any issues.
So, I want to ask.
Yeah.
So I wanted to ask, is there a difference if we use anti-VEGF and then followed by laser, or versus just plain laser in APROP cases? Is there a gross difference in the outcomes, or is it just variable from patient to patient?
You see, if you ask me, we did laser only for APROP all throughout for many, many years. And the problem is why I say that you give anti-VEGF in these cases, because mostly maybe 25 to 30% of them may not have a favorable outcome if you only do laser, because the success is not close to 90%. It will be around maybe 60, 70% in APROP cases. That's why we want combination treatment in many of these cases. But first, it will be anti-VEGF, not if you want to give, if you can laser it well, and you know it is not that severe, it is in the posterior zone 2, you do laser. It's a zone 1 disease, very severe disease, then perhaps your laser will also not be adequate. So that is where the problem happens. So that's why I'm saying zone 1 ROP. If you have a zone 1 ROP, maybe you have a case where you can use this as a primary treatment and then wait how it behaves. That is what I'm saying. Sometimes there may be a case you keep on watching, the vascularization is progressing, disease is not recurring back, then you can wait, then you are lucky. But in case it is coming back, which may happen in these cases, in quite a few of them, then don't wait, go and do laser at that time, but not very early. That is what I would say. Yes, Sangeet.
So one thing like you mentioned was that these retinas never get vascularized, or you can see some vascularization occurring over a period of time after anti-VEGF injections. So is there any cutoff time that, okay, now the baby has grown so old, this retina is still not vascularized. Shall I do laser at this stage, even if there is no proliferation? Is there any?
Yes, I think you are right, Sangeet. We don't have a clear-cut answer to this. We've been looking at these eyes, and we also finally, once we were taking them for examination under anesthesia, say 2-3 times, and it's not going beyond, and the baby has already grown more than a year. And then we also err on the side of doing laser in them. That is just taking analogy also from the fever cases, where, you know, these days we don't wait. If a fever, you find that there's avascular retina. So most of the time, such retinas are lasered these days, because I think we have now more input also because of the angiography being done in such cases, where that gives you much better idea, and you can define the area better, also see other changes. And that's how perhaps even in fever, it is a wide field angiography which has changed the management. And that is what, again, the maximum work, not only on ROP, even in fever, has come from Michael Tracy's group. So I think some of these cases where we were not trying to intervene earlier, if they are not getting, because we don't know this avascular retina, if it remains there forever, whether it is going to develop some atrophic changes, other things subsequently, or a late some pull or something, or they develop late detachment, we don't know that part. So maybe, I think, if it is not getting vascularized, and it has, we have lasered them. I remember that we lasered them around maybe 10 months, 1 year, sometime even little later than that, once it is not getting vascularized at all, and it is just sort of remaining where we had seen that. That is what happens.
Mohit?
One question, sir.
No, I think Amandeep can stop sharing the screen.
Yeah.
Yes.
Yeah. No, I think the only thing I want to say is that again here, like injuries, you have to prevent ROP so that we don't have to go into this. And I think even during COVID, we are recommending the patients to come. And actually, Mangat will be happy. Next 22nd next week, I'm doing a gold medal oration in the name of Dr. APJ Abdul Kalam by Dr. Michael Chiang, who's becoming the director of NEI. And
yes, he's a great man. He's done a lot of work on ROP.
Yeah, so
and his major interest used to be, you know, when he was in Columbia, in New York, and me and I still remember, me and Anand Vinekar, we had especially gone to meet him, because he's been very friendly with us, because we used to meet in these very many meetings. And that is the time he was going to the West, and he was the chairperson. And we are so happy that he's going to take up such a prestigious position. And he's done great work. And so he chose a great and a very nice, humble person for this.
So I'm making it as a public endowment lecture. So I want to make it a total, marketing for marketing ROP. And I have told my 2 consultants to do all out, saying that if there is a premature delivery, make sure you go to some retina specialist. Don't just go to ophthalmologist. Go to a retina specialist. And that's what I'm going to recommend, and make it public, this thing. And I'm happy none other than he's giving the oration, 4th oration. And,
oh yes, absolutely. Okay. That is.
So I will send you. And so I think all whatever, that's why I wrote to Mohit that you are the authority on treatment and everything. And I think from my side, as a past president of AO, I want to make sure that we prevent. We should do prevention. And I think all ROP, all premature babies should be screened. In spite of all the you are saying about less than 1.25, 1.5, I think Shubhadra Jalali, IROP, all has been done. But I just want to give one statement. Like, are you a diabetic? You may go blind, go to the eye doctor. And something, you have a premature delivery, please check the eye. That's all I want to tell. So that you don't want the public to know all this intricate details. And I told today also one patient, the way I tell like this, you think looks like I'm selling ophthalmology. I said, no, I'm doing something for prevention so that you don't spend money on ROP, laser, and then surgery. And then we have seen in the 80s, we have seen child going blind. And we have seen Steve Charles operating, Tatsu Hirose operating, and I have operated so many ROP. And I got fed up. And I one surgery which I don't like to do is ROP. because of this, because I have only seen ROP grade 5, and they all come in 3 months and 4 months. It's such a, I mean, terrible state, because I think now, because of the awareness created by Mangat, Azad, Subhadra Jalali, Anand Vinekar, and I'm happy that at least people know that, okay, the premature baby, you should do a screening. And I'm happy.
Absolutely. What you, yes.
We have that, I forgot the name, no new camera from Forest. So we are recommending that.
Exactly. Yeah. I was partly involved in that because I was very interested that we should have something, and that is what is going to be a big thing. What is happening is also that sometimes the retina is not being seen properly. They are not dilating well. They are not seeing, and they miss it. That's why probably the digital screening or this kind of a tele-screening is going to be coming more and more, and with cheaper cameras, which can be taken like a suitcase. Any person can take from one nursery to other once a week. That will be the way to go.
That is the work. Michael Chang is working on AI in ROP screening. And he is actually published in 17 itself. I just was reading all the articles where he's saying that he wants to bring this AI technology to smartphone, which is, I think, Anand Vinekar also doing. But I think we have to do it in a bigger way for both ROP and diabetic retinopathy, where I want to make a scheme which I'm working with Shroff Charity and Skill Development Corporation of India, which is a quasi-government, where we have done an experiment and published in JAMA and diabetic retinopathy, using illiterate people, like my room boy, like the 3 of them we have trained. They can use the smartphone to take diabetic retinopathy. And Casey and Anand Vinekar came to Aditya Jyoth, and they have told we can train similar people for ROP. So I'm in the process, but unfortunately the COVID happened, but now I'm training optometrists. But I want non-illiterate people, jobless people all over India, and we need some CSR funding, somebody to give the camera to go where all the wherever premature babies are there, and then they can at least say, okay, even if they have a false positive 1 or 2, at least they can go to the retina doctor immediately. And I'm thinking all over India, retina doctors are available. Whichever village, they can go in few kilometers to a retina doctor, maybe 50 kilometers. I think retina doctor should be available, right?
Absolutely. I think I agree with you. I think our mission should be, don't let them go to stage 5. You already mentioned about the surgery you did. So many people did. And Dr. Lingam Gopal started in this country. You know, he was the first person. He used to get so frustrated. I remember when you mentioned about Steve Charles, his major surgeries used to be ROP from all over the world. And he's the first person who left doing that. He doesn't do, for many years, he doesn't do ROP surgery because he also got so much frustrated.
Me too.
I frustrated because he got very poor result. So don't let them go there. We have to kind of tackle them before and diagnose in time, treat them in time, and even if they are progressing, catch them at stage 4, stage 5, and not let them go to 5. That is where the problem is. We get hardly then very poor result. Great comments, Dr. Natarajan, and a great thing that you are calling Michael Chang, which is a great, that be a great sort of a activity which will happen for our country. Absolutely.
Yes.
We have 2 questions in the chat box regarding ROP. I'll direct them to Dr. Dogra. So these are from Dr. Praveen Panwar, I'm guessing from Shimla in IGMC. And he asked specifically, and I think it's a pertinent question in today's time, that if you're, let's say, screening a baby either during screening, it's already known that the baby is COVID positive, or after screening, let's say you diagnosed treatable ROP and you asked for a COVID test and that turned out to be positive, and you might have planned laser for that baby, but given the fact that the baby is now COVID positive, would it be A, justified, and B, what would be the best way to go about to kind of tide over the period and ensure that the baby becomes less to non-infective and we can have a 2 to 3 week, maybe a month period? So would injecting at that time be indicated just to buy time?
I think if you go back, all of you, during the COVID times, we had it mostly kind of gone on to say, not really that you do injection in every case, but that be liberal about injections during COVID times. So you could give injection in such cases, and maybe you may have a bigger problem, even lasering, because the question is, they may not want their area get getting infected and other, you see, there are a lot many issues. So definitely the injections would be something which can be performed, and that they should be performed more liberally. And that is what we had indicated, because that will definitely buy a time. It's not only for a positive baby, for other babies also, where there is a scare, your team may not be that comfortable. You know what, you must have seen Subhadra talking these days. She made like a contraption, like a plastic box. She got this idea from that video, which I have shown almost all over the world, treating through the incubator wall. You can treat laser through that. She got an idea from that. And that's what she said also, that I got this idea from this Dr. Dogra's old this video, because that box is mainly because of that reason, the scare which is there. So I think laser is also not that easy a proposition during COVID time. That's why you can definitely buy a time. Maybe more liberal injections are required. And if you need to do laser, you'll have to take all the precautions. And you have to have on board your pediatrician, neonatologist, or anesthesiologist, whosoever, they should be comfortable with doing that. Absolutely.
So I just had a point. We just saw a C protein baby with vitreous hemorrhage and bleeding all over, and both, and that baby was positive for COVID. I don't know how. In 5 days they gave a negative report, and I had the guts to examine the patient. But I had a similar patient with a CRVO in a 17-year-old, father, mother positive. And when we did the COVID antibody test and DMR, it was positive. But then the patient requested I should do. I said, come on here, I am 60 plus, please understand. So I have an idea. I'm not against the young people. 30 plus like Mohit can take the PPA and do the laser. Why? Even if they get a COVID, nothing will happen. And then even for us, nothing will happen. As you rightly said, Mangat, I think nothing will, we are all positive people. And so I think young people with the PPE can do the laser with all the difficulty. Because yesterday I made, luckily she was not a COVID positive, I made the young doctor who was also have a twins. We have a Dr. Asta, a consultant. She was doing laser, and she was wearing the PPE and did the laser and everything. So I think we can take with the COVID positive. I think only thing is, I think usually in 5 days the things goes down in a child, and that too in a neonatal child, I think. And luckily they don't have a severe problem like the old people with comorbidities with the lung and going into the ventilator. I don't think it happens to the child, whatever I read in the newspapers, and I didn't read the article. But I think the eye surgeons who are dare enough, who are not having even 1% fear, they should do it. But if you have fear, don't do it.
Yeah, that is same. I think yes, you're right. I think they were doing, even in Mohit knows now. Of course, I'm not there in PGI. That they did quite a few surgeries in the COVID hospital there, which is a big wing, and these included some of these emergency situations where the COVID positive patients were there. So they did with full PPE, and they could do all that. So I think that's a very good point you have added, Dr. Natarajan. Thank you for that. Yes.
We are actually doing a study on a COVID patients also on fundus photo OCD in the COVID ward, and we are sending young people. I don't go. I only do as an investigation. So I don't mind going, because I don't have problem. But everybody say, "Oh, don't go, don't go." It's all right. We'll respect the other people. But I still feel 18 only.
Yeah, I know. You look still bad. We often talk about that here.
Yes, Mohit.
On that positive and cheerful note, sir, we'll move on. And thank you, Dr. Dogra, Dr. Natarajan, and everyone for the comments. I think as far as Dr. Ajay is concerned, as I had alluded to earlier, there's been a little bit of a emergency that's crept up in his hospital with, I think, one of his very close assistants who had some ocular emergency that could not be ignored. And it's been quite some time he's been in the OR, and we've not been able to get in touch with him. In fact, his phone is with one of his colleagues, and it's unlikely that he'll be able to join us. So whatever the problem is, we wish him well. And we move on to Dr. Abhinav Dhami, my dear friend, who's also a consultant at Dhami Eye Hospital in Ludhiana. And he does, he's been VR trained in vitro retina and uveitis, does ROP work as well, and is an avid cataract surgeon as well. And he's going to talk to us on something which is, quite frankly, as we say, the bread and butter of vitreoretinal surgeons. I think being retinal detachments and vitreous hemorrhages being the 1 and 2 of the commonality of the surgical VR load that we see. So Abhinav is going to discuss how his approach to managing vitreous hemorrhage. Abhinav, please.
Abhinav, just before you start, an anecdote. Were you there when I came to Ludhiana?
Yes, sir.
I met your dad. I think he was the president
Yes.
that time. Right.
Yes,
Anyhow,
yes.
I don't remember. Sorry, I didn't remember meeting you. I wanted to say, when I landed in the Ludhiana airport, I saw that was the smallest airport in the world, I thought. And then as soon as I got out from the airport, I got stuck in the railway gate, and then I remembered my school days, and I did a Facebook Live and said I've landed, but I'm half an hour or 1 hour stuck in the railway gate. So, and then same thing, I think, Dr. Amandeep, I met you there in Jalandhar.
Jalandhar, yes, sir.
Everybody they told me I'm like a fool, like going like this. We're from Jalandhar. My secretary booked a ticket to Amritsar for taking a flight to Bombay. Everybody said, why can't you go to Amritsar? Sorry, from Chandigarh. I came from Jalandhar to Chandigarh instead of going to Amritsar. So I said, this is an important thing. I love Punjab, and I think I did a Punjab tour that time. And I made Dr. What's his name, Ravijit Singh, and he'll come halfway to airport to meet me. I said, I don't want to come into the city, you come. So anyhow, my pleasant memories to Punjab as the president of All India.
Thank you, Mohit. Thank you for the kind words, and it's a great honor for me to be presenting amongst the biggest stalwarts of Retina. And I think I'll share my screen. I hope my presentation is visible.
Absolutely.
Okay. So as Mohit said, it's the bread and butter of VR, but I think it's way more than just looking at vitreous hemorrhage and deciding, because the era of management has completely changed, and there's too many modalities that we can look at. So when we look at vitreous hemorrhage, it's one of the most common differential diagnoses for certain painless decrease in vision. So if all note what we look at, we have proliferative diabetic retinopathy. Dr. Sangeet Mittal had showed all the variable cases. This accounts for 32% of the cases. Retinal tear, which may be subsequently from a lead to a retinal detachment, or maybe for PVD induced, about 30%. Proliferative retinopathy after retinal vein occlusions account for 11% of the cases, while PVD induction is less but needs to be clearly monitored, accounts for 8%. And sometimes you may just have a rupture of normal retinal vessel, lead to a breakthrough bleeding, and may not need any management. So all these cases require a different management, and I think that's what we're talking about. So when we look at vitreous hemorrhage, we look at two different headings. We have the proliferative retinopathy and we have the non-proliferative retinopathy. The proliferative retinopathy, we have diabetes, vasculitis, venous occlusions, and even sickle cell retinopathy. And the non-proliferative, we have period-induced trauma, vasculitis, Thurston syndrome, ARMD, retinal macroaneurysm, and the Valsalva retinopathy. Now, why is it important? Because the fate of vitreous hemorrhage is very variable. The amount of hemorrhage that the vitreous gel can clear is very slow, and the rate of clearance is as slow as 1% per day. For a 4 ml cavity, that's very less. So in cases that we don't treat vitreous hemorrhages, you can have cholesterol bulbi, you can have hemocentrosis bulbi, you can have ghost cell glaucoma or hemolytic glaucoma because of long-standing vitreous, and it blocks the trabecular meshwork. So we need to intervene in these cases. Now we know that the ocular examination is much needed. We need to look at the BCVA, we need to look at the presence of iris and angle neovascularization, because eventually these cases can land into a neovascular glaucoma. We need to look at kinetic precipitates, not just look at the vitreous hemorrhage. Okay, it's a vitreous hemorrhage, let's just operate. We may have a vascular cause or maybe uveitic cause that has led to the hemorrhage, and we need to monitor the intraocular pressure, because a lot of these times these patients can end up going towards neovascular glaucoma. And we need to do a retinal evaluation, a complete retinal evaluation with ciliary depression, not just with 90D, because at times you may just have a peripheral break, which just needs laser and not a complete vitrectomy, and we can just salvage get better outcomes. So when you look at the ocular examination, one of the most important things is the B-scan. We need to rule out whether it's detachment, a mass, or lesion or a plain hemorrhage. The emphasis should be on three sites: the vitreous cavity, whether how mobile or how are the clumps in the gel. We need to look at the vitreal interface. Is there a presence of any traction or any attachment onto the retinal surface? And we need to definitely rule out retinal choroidal layers or retinal or the mass lesions, which can masquerade as a vitreous hemorrhage. And simultaneous scans are crucial to plan treatment and prognosticate the outcomes. So when I look at these scans, I look at these three images. This is what the mainstay or the three cardinals I look for before I plan anything. Because a lot of times, what I think has been spoken of before is that there's a lot of rule that, you know, if you have a vitreous hemorrhage, just go ahead and give a anti-VEGF. So the consideration for planning any intervention can go through all these three images. If you have a look at the image A, now you know that there is, you see the B scan, you see a little vitreous gel, and you see this elevated tractional area. Well, these are the cases that do not require an anti-VEGF and need a surgery. You may give an anti-VEGF just as a pre-op for 1 or 2 days before to decrease the vascularity, but you need to intervene. Giving an anti-VEGF for clearing the vitreous hemorrhage may actually cause more trouble. Second again is, you know, you may see a subhyaloid hemorrhage in people, and you may think of giving an anti-VEGF. This itself may not be needed because sometimes the subhyaloid hemorrhage can have underlying fibrovascular proliferations, and they sometimes may be made more dense and may not clear at all. And you may end up just delaying the treatment modality by giving anti-VEGF. The third image is where the plus minus sign, that means I have to be more doubtful on treating these cases. You have a good clump of vitreous hemorrhage into the jelly, but you can see the posterior PVD. You can see a posterior mildly hyperreflective membrane. That means that the PVD has happened. I need to rule out whether it is because of a retinal break or a PVD-induced retinal break. I need to closely monitor these eyes. And these cases also do not need an anti-VEGF. So this is my three cardinal signs, because I don't really recommend an anti-VEGF as soon as you see a vitreous hemorrhage case. Investigation, yes, I do a complete cardiac workup, full lab workup, and the FFIC if necessary. You ultrasound, as I showed before, to rule out any subsequent factors. So the basic options of management come into four headings. We can observe, we can do laser photocoagulation, we do have anti-VEGF therapy, and we can definitely go ahead with passing a vitrectomy. So observation forms a very important part, because if it's a fresh vitreous hemorrhage and if you see that the other eye is totally normal, it may take clearance in a couple of days or weeks to allow for evaluation of a retina. We can just give a head-end elevation and reevaluate after 3 to 7 days. Sometimes the settling of the vitreum can give you a better answer. A PVD-related hemorrhage with no obvious clinical break can be just observed clerically. Oral ascorbic acid, vitamin C may not really help you for better clearance. So this is just a 20-year-old, I'm showing a small case. There's a 20-year-old male, sudden diminution of vision, no systemic disease, other eye was completely normal. I see the retina, there's a diffuse with haze. I actually thought this was more of a uveitic case or probably a vasculitic case, because I could see some amount of closed vessel in the posterior pole. So I waited and waited. I said, okay, let's not go ahead, let's not be too hasty. So we waited, we did an angiography. I just see this leaking vessel, but I waited for 15 days, and this is what it comes out to be, just an avulsed vessel. It's basically nothing, and he had these collateral loops. So I basically thought maybe it was an old case of venous occlusion, but you know, the FFA was not really helpful in that cases. And we observed and observed. We pretty much didn't do anything. Left the eye as such, and he's been maintaining 6 vision. The hemorrhage is settling freely. I didn't even do a laser. So I think these are some of the cases that you can actually just wait and observe and not do anything, because there was no active leakage, no NV developing. So I never even lasered this eye. Second is laser photocoagulation. I think laser photocoagulation is still the mainstay in all proliferative vasculopathies and should be started as soon as any part of the retina is visible. The standard care of PDR has been PRP, as the DRS study demonstrated that PRP can reduce the rate of severe vision loss to 50%. Even after partial clearing of the hemorrhage, one may visualize, even in case of PVD-induced breaks, we can visualize the retinal break or a reverse vessel that can be treated with barrage laser photocoagulation with any other delivery method, whether it's an LI or a slit lamp based. So it's a simple case, a 50-year-old female, uncontrolled diabetic, you know, right eye presents with a vitreous hemorrhage with good amount of leakage at the posterior pole on the mid periphery. Left eye also shows, left eye funnily had a fibrosis at the fovea. So I wait, give 10 days of head elevation, you know, and then followed up with laser. The vitreous hemorrhage in the right eye pretty much just decreased, and I could see a stump of NVD lying onto the disc. And with good rest, 6 weeks, about 2 months, there was a complete resolution. Didn't even need an anti-VEGF. Right eye, I did give an anti-VEGF followed. The left eye, because there was already a scarring. So I think laser PRP should be done in all proliferative cases. And in case you need to sometimes just wait and not just go ahead with an anti-VEGF. And these eyes may do a lot better. So anti-VEGF therapy in my scenario, we have seen the DRCR protocol S, and it has a randomized controlled trial to determine whether ranibizumab 0.5 was non-inferior for PRP, for PDR cases. So in 394 eyes in treatment naive eyes with PDR, randomized to 1:1 treatment with interval ranibizumab versus PRP, the average visual acuity change at 2 years was plus 2.8 letters in ranibizumab group and plus 0.2 letters in PRP. So you need to really understand that in cases of proliferative disorders, there may be some amount of a macular edema, which may have also helped in this case, which can be treated subsequently after you have lasered the eye. So including 98% of the PRP eyes received the as per the protocol, and 45 eyes needed a supplemental PRP for PDR progression. Only 6% of the eyes in ranibizumab would needed rescue PRP treatment. The development of DME was definitely less than ranibizumab, but with a lesser need for vitrectomy in the anti-VEGF eyes with respect to the PRP eyes. About 42% of the PRP treated eyes and 34% of the ranibizumab treated eyes did demonstrate progression of PDR, but that may be related to the systemic control itself. So when we look at proliferative disease, we need to look at it in a whole systemic view. We need to control the disease also as we are treating the eye. So it has to be a bimodal control rather than just an ocular control. So anti-VEGF can be used to treat the underlying retinopathy and may delay but may not reduce the need for surgery. There is no treatment method after which it is safe to discontinue anti-VEGF therapy. Studies have shown that once the anti-VEGF medication is stopped, neovascularization will recur and continue to progress. So you need to supplement it with PRP. We need to rule out the serious side effects like endophthalmitis, progression of traction lateral tightness after anti-VEGF therapy. And of course, the cost and time of anti-VEGF monotherapy is also a burden upon the patient. So this is of a simple case, they had a subhyaloid hemorrhage, given anti-VEGF, did supplement with laser and had a complete regression. So these are some of the easy cases that you can manage well with VEGF. So I think, but when it comes to vitrectomy, the indications of vitrectomy may be limited to eyes with good detached retina, good PVD, and a non-clearing vitreous hemorrhage over 2 to 3 months. Eyes will definitely, as Dr. Sangeet Mittal has shown, that eyes with advanced proliferative retinopathy, where vitreous hemorrhage does not clear in 6 to 8 weeks, even after you do adequate laser therapy, then needs a vitrectomy. Vitreous hemorrhage associated with lateral attachments and vitreous hemorrhage due to AMD or ITGV cases need an early intervention, may need an intra anti-VEGF supplementation. So just a couple of videos. This is a simple video of a vitreous hemorrhage. In all these pseudophakic eyes, I think the anterior hyaloid has to be removed. Dr. Sangeet was saying that you need to do a good base dissection also in these cases. So I start with the peripheral width, make sure to remove the amount of vitreous, the heme that is underneath the vitreous gel, and then cleave the vitreous in all peripheral sides. I go from periphery to inside. And as we go in, the heme just keeps coming with the active suction. This is actually a case where Ozurdex had been given inside the eye for vitreous hemorrhage. I don't know whether DME was being treated. This is from somewhere else. And so I ate the Ozurdex implant itself along with it. And we use the proportional reflux, clear the vitreous hemorrhage, and follow it up with laser, 3C laser. So I think the intra-op laser itself helps in solving the problem of the proliferative factor. And in the end, I think the case of tamponade, I think as Sir had said, that 90% of the cases you may just fill the cavity with air and get by with it. And I think second case, I think this is a vitreous hemorrhage with some amount of the traction component also. This was actually one of those few cases where when we went inside, we realized that there was a hard exit plaque at the macula. And I had seen a couple of cases where he had been doing ILM peeling for all these eyes. So we do a cortical cleaving, we do the peripheral vitreous cleaving, and we go a good base dissection. So by clearing the vitreous, I just soften little. I take the forceps and we just pull on the membrane at the disc and do an end-to-toe dissection. And see, the second membrane also comes along very nicely. In this case, I'm just looking at the tractional component. It's minimal, so I pull it in one go. But I see a huge plaque sitting at the macula, and I was wondering, this is where I think I had just seen Dr. Sangeet Mittal showing his case series where he had done ILM peeling. So after I was finishing the case, I thought, okay, let's just peel the ILM also. So I'm still waiting to see whether it resolves or not, because it's been 6 weeks. There's been very minimal resolution of the hard exit, but definitely has decreased. I think Dr. Sangeet Mittal can tell me further if that really helps. And in case where you go in and you have a huge tractional component, I think it's best to do a peripheral cleavage first, peripheral vitreous clearing, remove all the adhesions at the peripheral sites, and then go in inside, because it helps you in better cleaving and better membrane pulling. Because if we have a minimal vitreocysis that is still attached to the membrane, which may actually cause a iatrogenic break. So after clearing all sides, and we go ahead, just making sure to remove, cauterize any amount of bleeding vessel inside. Use a soft tip cannula to make sure all the heme is displaced, removed first, so I know whether there's a leaking vessel. Slightly gently pull onto the disc of the membrane and create a cleaving point. And just with the cutter itself, I think you can cleave through all the membranes easily. I think with the modern cutting cutters, it's easy to cleave the membrane base. And so again, followed it up with just a laser in the periphery, and I did create a small break here, but I think I was sufficient to put just gas inside the eye and end the case. So in the end, I think the most important point, I think, is the tamponade, whether what to leave inside the eye. I think 90% of the cases you can go ahead with just fluid gas exchange. In some cases where I do get some or may create a iatrogenic break, I may leave C3F or necessary depending upon how the case is. I am not so comfortable leaving a gas or C3F in phakic eyes because somehow I feel that the interior hyaloid has not been cleaved very nicely or removed very nicely, and somehow sometimes the heme gets stuck into the anterior hyaloid and gives rise to what was being talked before about recurrent vitreous hemorrhages and need vit lavage or resurgery. I think silicone oil has a very limited role where you have multiple breaks, or in cases where I know the patient is not going to have any, may not follow with me for a long time. I have left silicone oil in those cases. So in conclusion, vitrectomy offers a good and early visual rehabilitation for vitreous heme. Anti-VEGF should be used with caution, but supplemental PRP should be done for proliferative retinopathy. Observation of vitreous heme in cases of suspected PVD-induced cases should have a close follow-up and need to find the cause for it. I think that's it for me. Thank you.
Thank you, Abhinav. I think great presentation, very succinct, and I think you covered most bases and gave the most importance to the most common cause, which is PDR, which unfortunately India being the diabetic capital. And I couldn't help but notice, I think you're a left-handed surgeon.
No, right-handed. I know right-handed.
Oh, okay. Because the video, I mean, the cutter was coming from the left side. So I was like, maybe we don't generally get to see that often. But excellent surgeries, excellent surgeries, excellent surgeries. I'll just go straight over to Dr. Natarajan sir and ask him for his comments regarding his approach to a patient with vitreous hemorrhage without a obvious etiology. So patients who might not be either aware that they are diabetics or that they're hypertensives, and so in young and in elderly. So Dr. Natarajan sir, please.
You have to unmute.
Yeah. So one is I investigate the patient and make sure, I think every time vitreous hemorrhage of unknown origin, I always say that could be a BRVO or a CRVO, even though it's not a known hypertensive. And in India specifically, when they say no history of diabetes, no history of hypertension, I think you don't believe them, but they don't know themselves. That's why they say, I don't know. But I think the question is, even if the BP is normal that time, and if you see, you have to anticipate BRVO or CRVO. And I always tell them, do the workup for BRVO, CRVO, including serum homocysteine. And then also make sure his blood pressure is monitored and check for sugars, even if it is normal, but make sure you ask for HbA1c. And that's why I recommend that any patient, like maybe 30 plus, and the family history of diabetes and hypertension, they should have a record. Every year they have checked for HbA1c, BP sugar, and blood pressure periodically. And then only we can declare that he was zero, he was normal 1 year back, and now he is diabetic or a hypertensive. So, and coming back to the vitreous hemorrhage, I have many times now operate vitreous hemorrhage with a one-eyed patient. When the other eye is lost because of either neovascular glaucoma due to diabetes or hypertension or injury. And then if you have once upon a time Eales disease, and earlier we were waiting for long, but now with a 25 gauge and even 27 gauge with the expert, I say even if the patient is ready, even in a week's time, if it's one-eyed, I want to visually rehabilitate. And those patients, coming back to the first case of Dr. Sangeet Mittal, if it's a diabetic, make sure you reduce the intraocular pressure and no tamponade, so that the patient can start seeing from day one. Many times I tell the patient, you can see from tomorrow. Sometimes they have a haze. And so they will say, doctor, you said, that's why I tell them, I don't promise, but I said, we wish you can see from tomorrow. And then that's how we make I feel many times that like one night patient with a simple vitreous hemorrhage within 1 week with no TRD. When I meant simple, I don't consider any vitrectomy simple. And when I touch the vitreous, you have to be careful. You have to know what are the complications and make sure you do a thorough vitrectomy. And if there you see NVE, NVD, do a ERP. And if it is a rare, like you don't find anything, which is going to be extremely rare, it could be either a trauma, we don't know, but that patient will obviously tell. So I think one is anticipate etiology and then confirm it on the table. So my informed consent, nowadays we have a video consent and with the relative. And I also tell them that if it is a CRVO, if the macula was involved, you may not get good vision. But if the macula is normal, so I have a rubber stamp. Whatever the vision blocked due to retina may not improve. Whatever vision blocked due to hemorrhage may improve.
Absolutely. I think so. That is as clear as it can be. Thank you, sir. I'd like to ask Dr. Dogra now, sir, regarding his comments on this.
I think one of the things which, in fact, we have always followed in any vitreous hemorrhage coming where there is no view of the retina. And sometimes it also depends, was it an acute event? Acute event, we know, then we are always kind of not even knowing whether it was what Professor Natarajan mentioned about whether it was a whole vascular occlusion there, or it was something which sort of bled now, maybe vasculitis or other things. But we have to also keep in mind if the patient is already a known myope or he's in that age group, he's a pseudophakic, maybe it was acute PVD which happened. And so I think that is a very important issue which we should keep in mind. But what is important is that doing a ultrasonography in this. So I would like to mention here, we always do, because if there is no view, I think that serves many purposes. One is, suppose there is already now a posterior vitreous detachment and you have no adhesions seen with the vitreoretina anywhere. I think your case becomes straightforward. You know you're not going to land up into a major issues. But if you have multiple vitreoretinal adhesions which are seen on and it is a partial PVD, so maybe there is kind of a proliferative kind of a change happening behind. So I think it has an important role as far as ultrasonography is concerned. And if you have associated retinal detachment, if you can see, I think you don't wait then. If you have a retinal detachment with vitreous hemorrhage, you're not even going to wait. You're going to go in straight away. Otherwise, if we wait in such a case, we'll have a very poor prognosis. So I think it gives us a lot of things. I think ultrasonography in a case where there is a dense hemorrhage or it is a non-resolving vitreous hemorrhage gives us a lot of clues how we're going to proceed further. So that's very important. Of course, already Avinav mentioned very nicely about what we should be doing if we suspect it is because of retinal break. I have had instances where we just call them back, maybe within 3 to 4 days, because you just make them sit up and you might be able to see a break or even sometime a localized detachment. Because if you pick it up early, you're going to give a better result. Even sometimes it has happened with a very important VIP patient, I remember, who was on a tour in Europe, and somebody, they don't have many retinal surgeons there. They have to even change sometimes the countries. So I think after doing laser, there was a smaller hemorrhage and it became a dense hemorrhage. It became a total hemorrhage. He lost all vision. So then it is also a problem. I think the laser he could do probably somewhere in one of the European countries, but then the person is very scared that he has lost all vision. Now, in such a situation, definitely you want to go in early. You don't want to wait. And that is what I would say. If you go in early, maybe you will catch everything very fast. It may be just localized detachment and it has not involved the macula in most situations in these cases. And of course, I think you have nicely talked about all the complicated things which happened with the diabetics and others, which is the commonest cause. We don't wait these days. I think we used to wait. Me and Dr. Natarajan are from that era when we used to wait for such a hemorrhage but now, especially if we are seeing a premacular hemorrhage with a bleed, I think we are not even waiting. Probably we could do it next week if the patient is clear. That is what it is, because the early intervention is the key. We get much better prognosis, much better results in these cases. And so I think vitrectomy in such a case would be in order. And of course, if you are clear and you have seen it is a vascular occlusion, it's not that big a bleed, or it is diabetic, there are not many vitreoretinal adhesion, and you see it was kind of a situation where you can still give a anti-VEGF injection and sometimes even laser later. That also can be done. But you need to look at these cases very carefully, and always tell diabetic patient especially that maybe you will not clear up, but you are also lined up for surgery. And they should be cleared for surgery, I must say, from your physician, cleared up for surgery, so that it should not happen that you have given an injection and some kind of a contraction happen and you can't treat. Then it is a problem.
Absolutely.
Yeah, I think well said, Mohit. Sorry, Mangat. So both I got confused. Mangat. And I think you're right. I think I always say get a clearance and get a consent that whatever happens, you will not postpone the surgery. That's why they will tell, "Ghar mein ye problem ho gaya, iske liye nahi aa saka." I said, then you are responsible that you can't change the date of surgery. It's nothing to do with me. It's for your own eye. And the second one, remember, is sometimes you can have a bilateral vitreous hemorrhage due to Terson syndrome. And then I have seen, because I think the hemorrhage is via the pia and it comes into the eye, the PVD is a problem in Terson syndrome. I still remember, I thought, oh, vitreous hemorrhage, it's fantastic. I saw there was no PVD in sonography, and I said, okay. But it was like digging into the ice. Like it doesn't come. I mean, that's a few patients I saw in a pellet injury, but in Terson's is a problem. I think what we say, simple, oh, vitreous hemorrhage, a beginner can do. But if it's the Terson's case or a no PVD, I think it's a great challenge. Like you need an experienced vitreoretinal surgeon. And I think Dr. Abhinav showed fantastic surgery, and I think great. And then I think no surgery should be made it simple, whether it's cataract or vitrectomy, to the public. And I think we have to tell how meticulous we are and how much years we have taken to master this technique. And then after that, we are doing the patient. I think I've done fastest vitrectomy 6-7 minutes, but doesn't mean every patient we can do. And then and time is not. That's why one of the always I used to contradict Steve Charles, then I left it. I don't argue with him now. He always talks about speed, time, and number, and which I always say. I also do the same, but I don't want to propagate that to the public or to in the forum from the thing. It's not, time is not the main thing, and I think it is important. But you don't spend 2 hours for a 10 minutes vitrectomy, but at the same time do everything meticulously. Whether it's a vitreous hemorrhage, follow the same principles. Make sure you induce PVD properly. Now, why only for macular road? For vitreous hemorrhage also.
Absolutely, sir. I think very rightly said, sir. I have 2 questions actually, which have come to me on my personal number through people. So I'm going to direct them, sir. And I'd like to get Dr. Sangeet Mittal, sir's view on this. So if you were to look at, sir, traumatic vitreous hemorrhage, what would be your approach, Sangeet, sir, to managing traumatic vitreous hemorrhage? Let's say, PVD, no PVD, traumatic vitreous hemorrhage without retinal detachment, with retinal detachment, after open globe or closed globe injury. What would be your management protocol, sir?
Thank you, Mohit. One thing I totally agree with Dr. Natarajan and Dr. Dogra, sir, please, that vitreous hemorrhage, though considered very simple, vitrectomies are actually not very simple, especially the ones in which we are not able to see the fundus at all, because you don't know what you are going to encounter when you have cleared the vitreous hemorrhage. Even if you do best of your ultrasounds, it's sometimes you don't get an idea what you are going to face during the surgery. I've seen cases like we thought that we'll be able to finish the surgery quite quickly, and in the end we were left with giant retinal tears behind the vitreous hemorrhage, or submacular hemorrhages, large submacular hemorrhages below these vitreous hemorrhages, in which we are not able to see the retina at all. And the history taking in these patients is also very important. Especially, I remember one case of leukemia which we had operated, and we burnt our fingers over there also. Leukemias, the vitreous hemorrhage is very, very difficult to remove. It's so attached to the retina, you can't separate the hemorrhage from the retina at all. and you end up leaving a mess behind. Again, Terson syndrome, Dr. Natarajan has mentioned, is the vitreous hemorrhage is so dense, it's sometimes with your 27 gauge cutter or with your 25 gauge cutter, you are not able to even chew the vitreous in these type of patients. So history is also very important in these cases. And coming to trauma, earlier now I have realized that the sooner that I operate trauma patients, the better results that I get. Earlier, we used to wait 2 to 3 weeks, 4 weeks for the PVD, natural PVD to happen. But now I don't wait for that. I try to operate as soon as possible. Again, another thing is if there is a detachment again with the vitreous hemorrhage, you have to be very careful because sometimes you're not able to delineate where is the retina and where is the hemorrhage or the hyaloid, posterior hyaloid. So you have to be very, very careful in these type of patients. The ideal thing is to create one hole in the posterior hyaloid. Somewhere, if you have seen the ultrasound before, you know that there is a partial PVD here. So you can go in and create a hole there and then remove the skirt of vitreous all around 360 degrees and then proceed. You have to be very careful in these patients. So I think otherwise the management remains the same. You remove the vitreous, you clear the opacities, and then you manage the retinal detachment as you are doing accordingly. One last thing about the speed, people have mentioned. What I feel is like going slow is the best way to finish faster.
No, I think this is what I used to make a motivational talk, and I learned from Dr. Badrinath also. It is like a bee on the flower. Every activity has to have a purpose. That means you bring a forceps to the eye or whatever, I mean, to protect the conjunctiva and or putting a cotton bud. You have to have a reason. Simply, you cannot keep on cleaning the eye or just wondering what. And I remember in the 80s when I've seen some surgeons, I hold they'll be actually doing vitrectomy for what I don't know. They'll be keep on doing, the cutter will be on. And for hours they'll be doing, because actually you have to learn to see that transparent vitreous. And I know some surgeons, seniors to me in Shankar, have given up vitrectomy because they say, I can't see the vitreous. So I think we have to learn to develop that. So I think every like cut has to have a meaning. That means you're cutting something. It's not that just you're cutting the liquid there or the fluid coming in. So I think you have to know what you're doing. So if you do everything, and that's what I tell my fellows, that you don't see my hand moving like that. You do that, and that 7 minutes is like every minute is well spent, or every second is well spent. That means there's a strategy in the mind. And that's why I love Steve Charles' book, where he has put a logarithm, which is there in my mind. And that's why I say, on the last chapter of Steve Charles, what is that? Surgical self-education, which he says, the day before you plan everything, and that's why we have the drawing check. I remember even Dr. Tiwari, when he was alive, who nowadays nobody does drawing check. He wrote in the Facebook. I said, no, sir. I did live surgery on scleral buckling. And I said, I do. And even today, my fellow took a leave. I had a retinal scleral buckling. I said, I want the drawing. I had the drawing. So similar thing for vitreous hemorrhage also. I have a fundus photo, but I still say, draw and post it in my back of my wall. I have a habit checking the eye, checking the name of the patient, and then similar thing. I think every purpose, if you do that, as you said, slow is not the correct answer. I think what he's conveying is every purpose, every activity has a purpose. Automatically, you'll not waste time. And actually, if you have seen in an unedited video, they'll take the forceps, catch the conjunctiva, leave it. Catch the conjunctiva, leave it. That is because they are thinking something, doing something, and they don't have a game plan. And this is what Steve Charles has mentioned. You have a game plan, even for a vitrectomy, for a vitreous hemorrhage. But the opposition here is the retina and the vitreous hemorrhage. So yesterday I learned from somewhere, I forgot who, some motivational talk, that why call it opposition? You make them a team member. That means the retina and vitreous are a team member. So they have to work with you. That means you know where is the retina, where is the, like as you said, you don't know where is vitreous hemorrhage. So you make a team member and have a strategy and achieve it. And if there's something traction, there's a retinal detachment which is not picked up in the ultrasound, it is there in the lower nasal quadrant, extreme periphery. You tackle it, do a cryo or whatever pneumoretinopexy that time, like a fluid air exchange, and put the patient on position. So I think that you have to have a game change which has to work from the mind. So this is what is there in Bhagavad Gita and Ramayana, where or Napoleon Bonaparte or even what's his name, Hitler did it the night before they won the war. So I always do this. I have a mental vitrectomy, and this is what I'm learning in one of the course I'm saying, you say when mental picture of, make a mental video, and she taught me make a mental rehearsal also of the video. What is the rehearsal? Every detail, how the patient is coming in, how are you going to give the block, how you are going to put the speculum, how, if you see the American surgeon's notes, it says that the patient is wheeled in, patient is the IV line taken, speculum put. I just wonder why they are writing, but I think it's become a, automatically repeating what you're doing, and I think everybody will learn it. I think that's what I think I want to convey. Vitrectomy, whatever Dr. Abhinav Dami presented, not simple. I think great. And the whole session was great. I learned a lot.
Absolutely. I think I would like to add only one thing, that every case of vitreous hemorrhage, you see, this is for youngsters, those who are getting into this, must remove the posterior hyaloid. So that is something I think you don't leave it there. And it is so important that everything would happen if you have left that hyaloid back. So that is and this happens in young people. You have sometimes injuries, even posterior penetrating trauma, even much more, because that is where the fibrosis will happen. So I think the hyaloid removal is the key, even in foreign body cases. You see, sometimes this one gets so much frustrated, they will not move. No, then that is the biggest mistake one can do. And another issue is sometimes you're trying to chase that dense hemorrhage which is stuck behind the lens, and lens is clear. Don't chase that. Don't make that lens touch or something, or cataractus. And you can always leave it. It will go away. It will clear up many times. These cases may not need any cataractus because these are young patients. So I think some of these things we do learn, and we need to kind of work around that rather than chasing some of the issues where we may end up with another surgery where we can have otherwise a good outcome. So there's some of the smaller points I thought I'll also add to the trauma cases.
No, I think wonderful, Mangat. I remember Dr. Chandrapa Rashmi, whose name we have the video award. He brought his brother and did cataract surgery in my clinic. And I remember something my anesthetist told, and he told, you have to do the surgery as though this is the only surgery for him in his life. Don't do cataract and say after cataract will come, I will do YAG laser or capsulotomy. That's what he was talking about. He said, no, I want to do a meticulous surgery so that that's the only surgery you'll have for that eye. So I think every surgery should be done that so that we aim at the best for the patient. And I think that particular moment, don't do anything else. And I think it's there in the spirituality also. Be at the moment. So that means you're doing vitrectomy, and I think you have to have a game plan, as Mangat said. In the circle lamp, you have to examine the patient at the circle lamp, make sure that the vitreous hemorrhage, where the vitreous or the hemorrhage is close to the retina, and mentally plan how will you put the probe. Now with the interchangeable, those days we were having a sutured infusion line. Now we can change the infusion line, go from the lower temporal quadrant and do the vitrectomy, and again put the infusion line, change it. So that means 3 ports you can keep interchanging, so that you don't have to cross the lens at all. Like this you do. So in all the 3 places you can do, and you can avoid the lens. So that's why complication, if you're aware, and I remember in live surgery in Mexico, when Dijon again, he commented, oh, Natarajan. I said, I actually told without realizing in the microphone, my foot. I said, I have no iatrogenic complication because Dr. Badnath taught me how to avoid iatrogenic complication. I told him. I know it is, you cannot say that an 18% is acceptable or 10% is acceptable just because it's published in a paper. I said the publication is based on your surgery. So why not you make a publication based on your surgery, reduce the iatrogenic complication from 18% to 1% or maybe 0? No?
Absolutely, sir. Absolutely, sir. I think great points. And as always, sir, the message at the end was loud and clear from you, sir. Thank you, sir. And with that, I think we've come to the end. And unfortunately, as I said earlier, I think we couldn't have Dr. Ajay with us because of unforeseeable circumstances. And again, we wish him all the best with whatever the circumstance there is. But I'd like to, before I end, I'd like to thank our esteemed panelists, Dr. Mangat Dogra, Professor Natarajan, sir. Thank you for sparing time on a Saturday evening, and joining us and being with us and giving us all the pearls of wisdom that we needed, sir. Thank you, sirs. And also to all our 4 presenters, including Natarajan, sir, Sangeet, sir, Dr. Amandeep, Abhinav. Thank you so much again for taking out time on Saturday evening and staying with us all throughout and actually having a lot of time and giving us time for discussions and for actually having an engaging conversation rather than actually saying ki, the time is running short and we need to skip to the other one. I think that was what was there. We had quite a few webinars going on at this time. There's a lot happening with the launch of a new anti-VEGF product and other things. So a lot of the audience might have been kind of torn between webinars, but I think the message from this and the points that were discussed, I think, were all very great. And I would be failing in my duty if I don't acknowledge the constant effort of Mr. Anil from Ajanta Pharma and their support. So thank you, Mr. Anil, and over to you and for any final comments that you might want to have. Thank you.
Respected sir, thank you, Dr. Mohit sir. Sir, on behalf of my company, Prisma Division of Ajanta Pharma, sir, I really want to express my paramount gratitude to all of you for this mega webinar. It was a thoroughly enlightening and informative session for all the listeners. No point left, sir. You have all of have covered all the points. And I sincerely thank you so much to all the doctors, especially Honorable Dr. Mangal Dogra sir and Padam Shri Professor Dr. Natarajan sir, Dr. Sangeet Mittal sir, as well as Dr. Amandeep Singh sir and Dr. Abhinav Dhami, and mainly sir, Dr. Mohit Dogra sir, for their precious time for today's webinar, sir. And sir, secondly, sir, I request you, sir, and I also, sir, thanks to you, all of you, so in advance for the for your comments, sir, which will be help to us to make our future webinar more successful, sir. So
I think
thank you so much once again, sir.
Yes. And Anil, thank you very much on behalf of all of us. And I think Mohit said that unlike the other webinars where we say time is up, and that's what I think the lesson for you. And I think I call this as a webinuria happening. So
yes, sir.
in spite of that, I think with the diarrhea, we are all sitting here and it's not a problem. But I always said, I told this to Dr. Mukherjee for ocular trauma because he planned a monthly webinars on ocular trauma. So I think there are 23,000 eye doctors and another 3,000 who are not, or 5,000 who are not members of AOS and another 3,000 as postgraduates. And I think they're all hungry for knowledge. So if not all the 23,000,